Hi, good morning, Nishan sir.
गुड मॉर्निंग सर, क्या हाल चाल?
एकदम बढ़िया है सर। आप बोलिए, आप दिख नहीं रहे हो।
अरे देख जाते हैं।
Yeah.
ये लीजिए।
Yes.
How are you?
I'm absolutely fit and fine. I'm in Chennai for a reticon, Agrawal sir's place.
You're kidding me? Seriously?
Seriously, I mean it. See, I'm
अरे वाह।
dressed. Otherwise, I would not be in. I would be in as casual, any casual session. So now I have a talk there also at 9:40. So I thought I will finish my talk and then rest. That's a physical meeting, but they are hosting a physical meeting.
Oh, wonderful.
Yeah.
That is so nice. But traveling is easy now, no problems?
Yes, we don't have direct flight from Nagpur at this point of time. I took a fly via Mumbai. I reached yesterday only, spent time because wanted to catch up with a lot of old friends of mine from Shankar Netralaya.
Okay.
Spent a day yesterday with them, had a late night dinner, and now back to work. Back to work.
Wonderful. Wonderful, wonderful, wonderful. Good, good, good. So you're first, now.
Yeah, I am first. I would finish off and I would take a leave basically because I'm supposed to be there at 9:35 of I have a talk there in the hall. So I would just rush through. I will finish off my presentation and then push up.
No problem. Perfect. Sounds good. You could see my presentation now
Yeah,
when
yeah,
I
I
put it
could
up.
see. Yeah, I did
Perfect,
see.
perfect. Good, good, good. And how have you been otherwise?
But now since June, now it's quite busy.
Good,
The
not
rebound
bad.
phenomenon is there right now with the work. Surgical work
True.
at least, thankfully.
True, true, true. Wonderful. The Reticon is a good meeting in Chennai?
Yeah, these people host it once in a year. And Agrawal sir just texted me, it is a physical meeting, you have to come. So then I thought I was not sure about it since till Thursday. Then Friday I decided no, your senior man is saying, so I better Ajay. That's
Nice.
all.
They've just bought Aditya Jyot.
Yeah, Aditya Jyot. I know Mumbai, it's the third, no?
I think they bought one or two more. You're right.
Yeah, Dr. Vandana Jayant का भी पहले किए थे लगता.
Correct.
They're on a shopping spree.
आपको क्यों नहीं खरीद रहे? महाराष्ट्र में 300 करोड़ खरीदने हैं तो. The biggest clinic in Maharashtra, they've not looked at foolish fellows.
अरे यार क्यों मजे ले रहे हो? छोटे लोगों की तरफ उनकी नजर नहीं जाती है.
सर,
उनको बड़े लोग
जितना वॉल्यूम आपका होगा उतना आदित्य जोत का नहीं होगा अभी.
नहीं, that's different, sir.
You know, volume wise. But
yeah, I know.
Wonderful. I don't know what will Nati do then.
Nati would be working as a clinical director. That's what I.
Nice.
Yeah, he will be.
Good, huh?
I think property he might have retained. He might get rent.
Must have retained.
Usually the arrangement is usually like that. You enjoy the property and you only say he might have sold practice. That's what my way of looking at it. Not necessarily the physical assets. Practice means the instrumentation and
physical assets की कोई बेचेगा यार.
हाँ वही बॉम्बे में तो वो तो हॉट केक है the way place where
plus उसका rental से ही आपको में you don't need to work after that, no? If you got a good property, then the rentals are going to be enough for you to lead a reasonably nice life without all the hassle of running a hospital.
Yeah, it must be in lakhs of rupees for that property, I believe. So even if I don't know, Mumbai rates, I might be wrong, 15 lakhs rupees just rent आया तो साला क्यों आदमी काम करे?
Obviously, no. क्यों आदमी मरेगा यार? How many vaccines do you have to give to make that much money?
Very true, very true.
You know, not worth it.
Good. Sir. Good morning,
Namaste, sir.
Namaste. I am Dr. Jagdish Rana.
How are you, Rana sir?
Yes, I'm fine. I am organizing secretary.
Arey Bapre, thank you. Wonderful.
We are meeting for the first time. Yeah.
जी. The organization is unbelievable.
जगदीश सर, ऐसा है कि आपके ऊपर आपका बेटा छा गया इसलिए आपको कोई पहचानने को तैयार नहीं है, रेटिना वाले तो भी.
कोई बात नहीं, मुझे रेटिना में ऐसे भी पहले से इंटरेस्ट नहीं था.
People know Parth. Now you should better tell कि I am Parth Rana's daughter, father. Better है. हाँ, तब लोग आपको recognize करेंगे रेटिना सोसाइटी वाले, क्योंकि Parth has really created a niche for himself in retina society in a very young age.
You see, I started in conference, attending conference, other chairing this and as a faculty after 40, 45.
Okay.
And he started at 30 years. So it does make difference. No? 10 years ahead.
नहीं सर, आपके बेटे में कुछ बात भी होगी ना?
हाँ वो तो है ना, वो तो है, वो तो है, हाँ वो तो है, वो कुछ ना बात तो है, सही बात है. Yeah, we started organizing Ahmedabad Ophthalmic Conference in 2015, first time.
Yeah.
And then now Gujarat and everything, so it does make difference. It is excellent, yeah. Hi, Dr. Shilpi Shah, how are you? Shilpi?
Good morning.
Yeah, good morning.
Good morning, Dr. Shilpi.
Good morning, Bankule sir. How are you?
Absolutely fit and fine. Raring to go. It's 8:57, I believe.
Yes, yeah, we can get started. So, and Rana sir, I might have to leave after 40 minutes because I have to give a talk at another session. Would you be kind enough to complete the moderation of this session?
See, I'm not a retina surgeon, but I will moderate.
Thank you so much. Thank you so much. I'm sure Khamar sir is there, Bavankule sir is there, Nishant sir is there. So it should be.
Bavankule sir is also leaving.
Yeah.
That's the problem.
No, the thing is, I am basically committed. I am in Chennai for Reticon, Agrawal sir's physical meeting. So I have to talk exactly at 9:35. So the moment I wind up here, I have to rush to that hall and then present. I'm right now in my room in a Chennai hotel.
All right, busy.
So just take leave from every one of you. I'm really sorry for that, but
no, thank you for joining.
राणा सर को नहीं बोल सकते.
Okay. So we'll get started.
Yeah.
Okay. Good morning and welcome to this medical retina session. Where we'll discuss about the updates on the AMD and DME management mainly. Without wasting further time, I'd like to invite our first speaker, Dr. Prashant Bavankule sir, director at the Sarakshi Netralaya in Nagpur and a reputed vitreoretinal surgeon there. He has been an ex-consultant at the SN Shankar Netralaya, Chennai, and he's also an honorary professor at the Government Medical College, Nagpur. He has been involved with multiple orations and awards. He is a much sought after speaker, and he will update us with the PCV management. Over to you, Bavankule sir.
Thank you, Dr. Shilpi. I would share my screen. Can you see my screen?
Yes.
Yeah.
Okay. See, basically, I was supposed to speak on vitreous hemorrhage associated with PCV, so I would be speaking on that particular talk of mine. So, friends, PCV lesions are otherwise also fragile and they tend to bleed quite easily. And the incidence of subretinal hemorrhage, which we are all aware, is as high as 30 to 63%. But the breakthrough into vitreous cavity happens in almost 4.5 to 20% of the patient. Let's share a few of the cases to understand how this disease behaves and what should be the ideal management. She's a 50 years female who complained of sudden decreased vision in right eye for 6 days duration. And you see at the fundus at presentation, you could see a large tubular serous PED type of a presentation. We did an OCT, we saw that it was PED, there was no intraretinal fluid, angio was done, angio was not contributory, but for blocked fluorescence, ICG also did not show any polyp or any PCV-like lesions. So we decided to observe because she was a young patient, no fluid, so the protocol says you should observe. And look what happens 3 weeks later. She complained of further sudden loss of vision and her vision had drastically reduced to 2/60. And this is the thing, you had a massive subretinal heme and you can see almost like a subhaloid hemorrhage, but it was not subhaloid. This is just a intraretinal type of a picture. And the OCT was more frightening. You could see tall PEDs and at this point, we didn't have much option. He was given an option of Eylea and the patient couldn't afford. So we went ahead with first biosimilar anti-VEGF injection was given at that point of time. But 8 days later, she complained of total loss of vision and she had total dispersed vitreous hemorrhage. We did a B scan. We saw there was vitreous opacity corresponding with the hemorrhage and the mass lesion at macula again corresponding with the previous PCV lesion. We continued with conservative management and we had planned to continue anti-VEGF injections at monthly interval. Well, she presented to us 6 weeks later after the first. Meanwhile, she sought an opinion at higher center who also advised conservative management with continued anti-VEGF injections to be given at a monthly interval. And this is 6 weeks later, her dispersed vitreous hemorrhage, moderate vitreous, mass lesion was almost as before. We went ahead with second anti-VEGF injection at that point of time. And then after second injection a month later, she had further increased. There were multiple episodes of breakthrough bleed probably. The lesion site by that time on a B scan had decreased. And so we decided to go ahead for better monitoring to do vitrectomy. So vitrectomy was initiated. As you can see, it looks classic chicken fat vitreous hemorrhage. The whole vitreous is studded. Unfortunately for us, the PVD was total. You can see on a picture a large subretinal mass lesion, subretinal heme, some exudates encroaching into the foveolar vascular zone. So after vitrectomy, we injected anti-VEGF injection. And this is the post-operative picture for you. You can see at day 1, at week 1, at week 3, and at 1 month, this was the lesion. Still, there were some subretinal hemorrhagic lesions which were active. So we went ahead with further injections of anti-VEGF. Then at 2 months, still the PED lesions in the periphery were active. We went ahead further with anti-VEGF. At 3 months, further anti-VEGF was given at Q4 interval. And this is 4 months later, patient had recovered 6/12 vision. PED had nearly flattened. We continued with anti-VEGF. We wanted to go for a kill for the PED lesions, hemorrhagic PED lesions. This is 9 months later when she had a grade 3 nuclear sclerosis. We observed, and this is 1 year later, and this is 1.5 years later. So just a timeline for you. This is at presentation 3 weeks later, 1 month post vitrectomy, 4 months, and 5 months, and 1 year, 1.5 years. Since then, the disease is in remission. Case 2, 70 years female. She's a gynecologist from our town. She presented with a serious PEDs over here. Large tall PED on an OCT. FFA showed some leakage. 3 dosages of injection aflibercept were given. Well, after 3 injections, 4 weeks later, her vision had come back to 6/9 parts. But 7 weeks later, it came back with vengeance. We could see more taller PED. And at that point, we repeated an FFA. We thought we are seeing leakage. On an ICG, we thought we are seeing a polyp. So we went ahead with PDT with injection aflibercept at that point of time. And this is some timeline for you. Repeat second, 1 month later, 2 months later, we continued with Q4 aflibercept. And this is at 3 months later, and this is 4 months later. The peripheral PCV mounts were somehow not responding at all. And 6 weeks later, following 4 injections post PDT, there was floaters, and she presented with a central core vitreous hemorrhage, through which the lesion could not be so well ascertained, but OCT did show that the lesion PED was there. We went ahead, continued with injection aflibercept, and this is 1 month later, injection aflibercept, 2 months later, and simple. In this case, we did not need vitrectomy, and you can see the organization, the scarring which happened in the peripheral lesion. The fovea was fortunately spared, and we could recover a good vision. And this is 3 months later, 5 months later, you can see the picture. So this is just a timeline. It presents as a serious PED, tall PED, post 3 injections. Then 7 weeks after 3 injections, back with vengeance. PDT done, 5 injections of aflibercept given, and 6 weeks after 5th injection, you can see, and 1 month and 3. Case 3 is a 85 years female who complained of sudden decreased vision in left eye. She had total vitreous hemorrhage. We didn't have posterior view. We did a B scan which showed dense opacities with dome-shaped mass lesion at posterior pole, which had a characteristics described here. We went ahead directly with pars plana vitrectomy, and you can see again it is a total chicken fat vitreous hemorrhage in this case. And the moment you remove this chicken fat vitreous hemorrhage here, the vitreous vitreous was sticky. We had to induce PVD, and after the induction of PVD, you can see large subretinal hemorrhagic mounts over there. So we went ahead, did a fluid gas exchange and positioned along with anti-VEGF injection intraoperatively. And this is what we did. Intravitreal anti-VEGF was also given, initiated, because we should go for treating the lesion as well. Hemorrhage is only a sign of that disease. We needed to treat the PCV lesions. So this is post-op follow-up, 2 more injections of anti-VEGF. 1 year later, other eye was diagnosed as ERM with PCV. And after 2 years, she presented again with decreased vision in left eye, hemorrhage. She underwent vitrectomy ILM peel with 3 dosages of anti-VEGF even in that eye. And 5 years later, again, she had a second recurrence. And you can see how the picture looks now. The left eye, the disease had gone in quiescence while he had bled. She has again bled in this particular eye. Well, after rebleeds, we only had to do fluid area exchange and we treated her with anti-VEGFs. Case 4, she was diagnosed elsewhere as peripheral exudative PCV. This is the picture on B scan. We directly went with pars plana vitrectomy. As you can see, the lesions over here at the posterior pole. The media was not that very clear in this particular case because of the dispersed vitreous image, even in the antechamber which has spread. And the post-operatively, she recovered 636. But yes, again, we had to treat the lesion. So we continued treating her with monthly injection bevacizumab, 3 more injections. And 4 months, she recovered 636 from hand movements. 2 years later, there was a reactivation of PCV with a vitreous hemorrhage. We did fluid gas exchange with simple injection, Avastin. It's a OPD procedure. Also, we could, after removing the hemorrhage, we saw some peripheral region. We treated her with triple freeze cryopexy. And this is the follow-up 1 month later to recurrence. And this is the case sheet for your diagnosis sheet, which we have how she has been treated since 2016 till 2019. The last case in this bouquet of PCV cases, she had received 7 anti-VEGF injections elsewhere, and she complained of sudden decreased vision. And this is the picture which you can see. OCT was here. You can see the PCV lesions, the serous PEDs. FFA was not much contributory. We continued with monthly anti-VEGF injections in this case. 6 months later, sudden decreased further vision. We thought we are seeing choroidal mass-like lesion. We did a B scan, and you can see massive, almost kissing choroidal-like picture. And this is what the picture was. We did B scan. We decided to observe because we were almost sure clinically that this must be a PCV, but we wanted to observe and buy some time. 2 weeks later, there was some reduction in the height of the mounts. We continued with observation. This is 5 weeks later. Then at that point, the mounts had substantially reduced. We went ahead to treat the vitreous hemorrhage. We did vitrectomy with injection anti-VEGF. As you can see, the dispersed vitreous hemorrhage gives a poor view because the hemorrhage had even poured it into antechamber. We washed multiple times the antechamber, but the media remained hazy. And after doing a vitrectomy, you can see the hemorrhagic mounts over there. Post-operatively, at 1 month, she recovered 1/60. This is the OCT. She received 2 more injections and she came back to 6/36. So friends, PCV can be associated with hemorrhage. The commonest differential diagnosis at that age is melanoma. How do you differentiate it? Basically, you should go for a B scan. B scan shows characteristics, high surface reflectivity, internal mild to moderate reflectivity. There's no excavation unlike melanoma or, usually and on a serial B scans, what happens, the size of the lesion does not increase. In a melanoma, there would be increase. So that helps you in catching up with the diagnosis and confirming that it is a PCV. And PCV lesions, just doing a vitrectomy is not sufficient enough. You have to treat the lesion with anti-VEGF following doing a vitrectomy. Thank you. Thank you.
Thank you so much, Bhavamkule sir. That was an excellent presentation with detailed documentation and long follow-ups. PCV is, as we know, a very aggressive form of AMD, and we have to be persistent with, as you said, multiple anti-VEGF, PDT, and vitrectomy as and when needed. I'd like to invite Kamar sir and Nishant Kumar sir for your comments on this.
No comments for Bhavamkule.
Hi, Nishant sir. Bakulesh sir, आप बोलिए बताइए थोड़ा.
नहीं, कुछ नहीं. See, we are only 4 people who are listening or talking. So we can chat.
No, I think wonderful cases that you brought up, and I think the other thing that you very nicely demonstrated, at least in 2 of your cases, was that sometimes the PCVs are not just restricted to the kind of macular area. You see a lot of these peripheral lesions as well. And I think in an older person, when you see kind of a vitreous hemorrhage and the known case of AMD, then, as you said, you can take a wait and watch, because there's a leap of faith that I can't see a detachment. Most probably it is a PEHCR or PCV lesion. And the problem sometimes jumping in with a vitrectomy is that the further anti-VEGF injection, the duration of treatment reduces, because then you don't have the vitreous there. So you're reducing your ability to treat these people on a long-term with a treat and extend basis by going in. So sometimes, like you showed, that some cases the vitreous hemorrhage might just clear on its own. So not being very aggressive. I know we're all surgeons and we like to say, hemorrhage, let's go in. But if you think about this, just 3 steps ahead, the 3 steps ahead that they're going to need multiple anti-VEGFs, whichever one you choose. And if you remove the vitreous, then you actually reduce the kind of half-life and the activity of the drug. So sometimes leaving that vitreous behind, seeing the vision, making sure the retina is not detaching is a really good idea, as you very nicely showed that this is not one of those cases where you go in straight away. I think you can kind of afford to wait, which is a wonderful demonstration, and that you need to treat the primary lesion is the most important thing.
Thank you. Thank you, sir. I will take a leave. I have to present once more at Reticon.
Yes,
Sir,
thank you so much, Dr.
Yeah, thank you.
Okay. So we move on to our next talk, which is by Dr. Kamar sir. Our own very Kamar sir does not need much introduction. Besides being a great clinician, he's an excellent teacher and an academician. He's a research director at Cadillac Pharmaceuticals. Over to you, Kamar sir.
Okay. Thank you, Silpi. Can you see the screen?
Yes.
Okay. So I'll talk on anti-VEGF past, present, and future. So if you know, first anti-VEGF which was approved was Macular in 2004. At the same time, bevacizumab was approved for colorectal cancer. In 2005, people started using bevacizumab initially for wet AMD, systemic, intravitreal, followed by diabetic retinopathy, rubiosis, and then subsequently whole spectrum of disease. Lucentis got approved in 2006 for wet AMD, followed by retinal vein occlusion in 2010, diabetic macular edema in 2012, and diabetic retinopathy in 2017, and myopic CNV in 2017. Eylea got later, 2018, originally for wet AMD, but it picked up very quickly, got approval for DME, RVO, diabetic retinopathy, and Beoya or brolucizumab got approved 2020. Now, what are the differences between all the anti-VEGF? So if you look at it, molecular weight is highest with bevacizumab and lowest with brolucizumab. But if you look at a dose, you give a higher amount of brolucizumab because you can pack more, and lowest amount of ranibizumab. If you look in terms of molar equivalence, it is 22 for brolucizumab and 0.8 for bevacizumab. How other properties of the 3 molecules which we use translate into real life. So binding affinity, molar dose is though high with brolucizumab, binding affinity is maximum with aflibercept. While potency is low for potency to reduce or neutralize VEGF is also high with aflibercept, and half-life is also high. That means it stays longer in the vitreous, but more important than that is how much it stays into the ocular tissues, and it says 1,000 times more compared to ranibizumab in the tissues. And this is just a video to show how it is different. So it traps VEGF as well as PEGF. Unlike others which neutralizes, this traps it and does not allow it to function. If you look at all the VEGF we have, most of the products work only on VEGF-A. Aflibercept work on VEGF-B as well as PGF. Now, this extra molecular target gives you increased chance to fight against angiogenesis and inflammation, and it also reduces diabetic hyperglycemia induced apoptosis. And this has translated into clinical scenarios where aflibercept has some advantage over other VEGF. This is shown as a signaling pathway. How does it do? So again, it says that there's a better control of inflammation and angiogenesis when you aflibercept compared to bevacizumab or ranibizumab. In diabetic macular edema, this translates into better resolution of edema at 24 weeks and better visual acuity and better central thickness control over time. So these are the individual studies, but this is a meta-analysis which again suggests that aflibercept is better than bevacizumab and ranibizumab for diabetic macular edema in terms of increase in visual acuity or decrease in central retinal thickness. Then when DCR-NET protocol T was re-evaluated, it was found that in NPDR, all the three drugs are equal, but in the PDR, diabetic macular edema improves better with aflibercept, which is 70% compared to 38 and 30% with ranibizumab and bevacizumab. And serous detachment with diabetic macular edema is a problem for anti-VEGF. Here, aflibercept works little better compared to the others. And if you look at the trends, aflibercept, though gained approval later, it has started taking over the share of Lucentis over a time, but bevacizumab continues to be prescribed maximally. For a branch retinal veil occlusion, there is no difference between the three. However, when you have a central retinal vein occlusion, in all the patients, if you compare as a group, there is no significant difference, though there is a marginal visual acuity improvement. But in ischemic CRVO, the difference is of 2 lines between ranibizumab and aflibercept. When you are treating resistant macular edema, and if you switch, again the results are better when you have ischemic CRVO compared to non-ischemic CRVO. And as in diabetic macular edema, even in retinal vein occlusion, bevacizumab is highly prescribed even in the US, where the cost is not a constraint, and aflibercept is picking up very fast. In a neovascular age-related macular degeneration, meta-analysis reveals that there is identical efficacy, but usage of aflibercept is significantly higher compared to the ranibizumab. And bevacizumab, even in the US situation, cost is a constraint, and it is believed that in 7-year period, it saved $17.3 billion. Then came brolucizumab, and Hawk and Harrier trial showed that you can reduce the frequency of injection when you use brolucizumab, and this was a welcome step. But then came Altair trial, which also showed that it is possible to reduce the duration of frequency, number of injections drastically if you monitor your patients well, and 60% of the patients can be managed at 3 months or a 4 months interval while maintaining the visual acuity. However, this brolucizumab got a setback, and this editorial which says that retinal vasculitis, which is seen with brolucizumab, which is associated with retinal vascular occlusion in significant number, is a significant problem, sight threatening, and you should use this drug as with a caution. This is ASCRS steering committee report, which says that retinal vasculitis causes a permanent decrease in vision rather than increase in vision. And if you look at what is the currently highly prescribed drugs or highly sold drugs, aflibercept is the highly sold drugs globally. It happens to be the 5th largest selling drug globally, while ranibizumab has a very low count and it does not appear in top 20. So what is likely to be future? What we are likely to do, or what we are likely to receive as a therapies? So these are some of the ideas which people are trying. So reducing injection burden is a major concern, and faricimab, which can be given every 4 months, is found to be non-inferior and it is likely to get approval either next later part of this year or early next year. Port delivery system follows the same trend. You can do this every 6 months. So reduction in visit is drastical. It is likely to get approval. Abicipivir, which also had identical efficacy with a lower burden of injection. However, intraocular inflammation rate was very high, like berlucimab, and FDA has refused to approve it currently. Then people are trying to do depot preparation of a TKI, tyrosine kinase inhibitor. We borrowed bevacizumab from the oncology people. So these are TKIs which are borrowed from oncology people, which are approved for various oncological indications. And it is a small molecule, and it is undergoing clinical evaluation, and it is expected that we have to give only 2 injections. The other is a conjugation of antibody with a polymer, which is also likely to provide durable response and reduce frequency. Then there are gene therapies, and there are 4, and they are likely to reduce frequency of injections and improve efficacy. Then people are trying to do orally so that patient does not have to come to the doctor or a hospital for an injection. And these are the 2. One is oral and another is a topical, which are currently holding good, and time will tell whether we will have an oral treatment or a topical treatment. Then for a better efficacy, people are trying to target various other VEGF. So one product is targeting VEGF-C and D, and when combined with ranibizumab, it improves the outcome. There's a 3-line improvement. Same way, I mean, there is a list where you try to do it in a different way. So icon 1 is another one, which is a basic binds to tissue factor and natural killer cells, and trying to improve efficacy in terms of reduction in CNVM size. However, it has not shown that effect in clinical so far. So other TKI inhibitors, they target Tie2 like faricimab or like aflibercept, and then there's an implant system like Ozurdex. So these are likely to improve efficacy of our current therapies, and we might be able to maintain or improve vision in all these conditions for a longer period of time. However, in spite of all these Pandoras of treatment options, each one has its own advantage and preferences, and this was Rosenfeld said. Like bevacizumab is cheap and aflibercept is cheaper in a certain indications. He treats bevacizumab and aflibercept when bevacizumab does not work. In the current scenario, our goal should be to maximize the visual benefit and maintain it for a longer time. And we need to individualize based on efficacy and convenience, which includes visit frequency and interval, logistic problems, and also look at economics. And we need to be proactive in selecting a particular drug for a particular patient and participate and have a little longer discussion or a chair time. Aflibercept offers some advantage over others in terms of lower injection burden with a desired safety profile, and its dual mechanism leads to faster visual recovery when you want it quick results, and it has a better efficacy compared to others in selected situations. Thank you.
So it was excellent and exhaustive talk about this anti-VEGF by Dr. Khamar sir. So I am an anti-segment surgeon. So any comment from Dr. Nishant Kumar?
That was a wonderfully well summarized kind of talk. And I think, Khamar sir did a wonderful job at just looking at all the currently available drugs and all the exciting things that we can look forward to. And just my 2 cents, I've been part of the VIEW study. I was an investigator when I was in England. I was part of the investigating team for the VIEW studies. I was part of the team that launched ILEA in New York. At that time, I was working with Larry Uzi and Rick Spade. I launched it in the UK because at that time I was a consultant in Moorfield. So there's always a lag between different countries. It always comes out in the US first. And I think Kamar sir very nicely said that, that we are kind of most probably reaching a saturation point with the anti-VEGFs would work against VEGF-A. I think, brolucizumab is one of them, bevacizumab is one of them, ranibizumab is one of them. Of course, ILEA was a game changer because it's not a monoclonal antibody. It is a fusion protein. It works differently. Its mechanism of action is different. Plus, it gives you a VEGF-B advantage. Plus, it gives you that placental growth factor advantage. So I think it offered us something more. And I think clinical studies have shown that I think today it's the drug of choice. Definitely for PCV, I think globally, there is no argument about it anymore that you've got a PCV lesion. I think ILEA is the drug of choice. For DME, I think most people would start off with it, as Phil Rosenfeld very correctly said, that it's a treatment of choice. But is there a space for other drugs? Of course, there is. The new kid on the block is, of course, BioView in India. It's called Paganex. A lot of promise initially. And then as Dr. Kamar said that, then again, the problems came up with this inflammation and the occlusive vasculitis and the vitritis. And actually, we're seeing that in India as well. They've sold quite a few kind of drugs. So credit to them that Novartis has a very nice kind of, distribution platform. So they were able to get inform people quite well. But we are seeing the inflammation. It's not that it hasn't been seen in the Indian patient. I think the incidence rate is anywhere between 8 to 10%. And most probably that's an underestimate. And that's a lot more than any of the other two drugs. And the vasculitis is difficult to diagnose if you don't do a fluorescein angiogram unless you get an occlusive vasculitis. But if you see some inflammation, then that's a problem. And I'm in total private practice, as Kamar Sahab must be, and so you, Rana Sahab. If a patient has an issue, then the issue becomes yours because the consultations become yours. There's more chair time, there's more headache, there's more phone calls. The patient doesn't understand that it was a drug. They say, Dr. Sahab, aapne kiya tha, aap jhelo isko. And there's a cost, so do you charge the patient for the OCD? Do you charge the patient for the angiogram? So I think safety first. I think do no harm. At the moment, I think, we've got some very good and safe and efficacious drugs. So I think everything else is kind of a salvage treatment. But the newer drugs are great. One of my colleagues who was with me in the UK is now leading the new molecules at Roche, and faricimab is from there, the Ang2 protein inhibitor with the anti-VEGF, which is showing some great results. It seems that Kamar Sahab will correct me that all of these will kind of are benchmarking to either ranibizumab or ILEA, depending when the trial started. But all of them are giving about the same visual results. The duration of treatment is what they're playing on. So some are 8 weeks, some are 12 weeks, some are 16 weeks. The port system hopes to kind of reduce treatment burden, but none of them are being able to get through that holy grail of that fibrosis, of that kind of, atrophy, which I think is going to be the holy grail, because I think we've done quite well in kind of in controlling the exudative process, which is the hemorrhage, the fluid. The next step is going to be how do you replace the cells and how do you prevent that scarring from happening? Because actually what kills vision is that retina, which is viable, is replaced by fibrosis. So we had the Fovista trial, which was the platelet-derived growth factor, which showed some wonderful results in phase 2, but nothing at all in phase 3, and therefore didn't kind of take off. There've been lots of trials looking at kind of, things like anacortev acetate to be given, which is a steroid type of drug to reduce fibrosis. So I think for us in the next at least medium to long term, which is 3 to 5 years, anti-VEGFs are going to be the stem of treatment. I think it's wonderful to see that people in India are moving away from Avastin, because my only comment is when you see Avastin in clinical trials, or when you see Phil Rosenfeld saying Avastin is my drug of choice, or bevacizumab is my drug of choice for initially, remember they're getting this drug from a compounding pharmacy. This drug is checked for sterility and potency. It's not the same Avastin we're getting in India. It's very nice to see these Americans, the Singaporeans, even in Moorfields or in Australia, they have special companies who take Avastin, put it into a unit dose, check it for sterility and purity, deliver it to you. It's almost as though they're running a separate pharmacy. It's not like the Avastin here, where we don't know where the Avastin molecule is coming from. One vial is punctured multiple times. Temperature control is an issue. Rate of infections can be a big problem. The Avastin they get is the A+ Avastin. The Avastin we use is the Z- Avastin. Please remember that don't compare these clinical trials to what we have. Kamar sir, your comments, please, because मैंने तो बहुत बोल दिया.
Okay. So basically, I mean, what happens is there are disruptive innovations and incremental innovations.
Very nicely said. Very nicely said.
So what we are currently, I mean, seeing is incremental innovations. But if you want to really go into the heart of a problem, we need some disruption. So we don't see any disruption coming in the horizon in near future. So we will continue to have patients coming to us. They might come less frequently. We might prefer one drug over the other. We might have a little better handle here, little better handle there. We might do things little differently, but it's not going to change drastically. So people will go blind after paying to us.
And I think that's the way you said it is beautiful, you know, that incremental versus disruptive. I think, you know, Lucentis was the first huge disruption in retina. It changed, I think, everyone's lives, the patient life, the doctor's life. Out of that, I think Eylea was semi-disruptive because it was a new molecule, a different way of looking at things. And then after them, all of them have been incremental, thoda idhar, thoda udhar. You and me might have a personal choice, you know, a geographical choice, a cost choice. I think as long as safety is not compromised, which is the problem, and I think that's why one of the drugs that you very nicely said, which showed a lot of promise, but lots of inflammation, the Peglars, you know, which were thought to be the new thing, which is kind of that you give it and it's like a depot and therefore it lasts up to 16 weeks, but the inflammation was in the 10 to 15%, you know, that's why it's not going anywhere. So of course we have to try lots of different ideas. Even the depot systems, the endophthalmitis rate was something like 30%. So obviously, if you put a wick into the eye, which is open to the outside, your risk of infection is going to be very high. But unless you try, you're not going to know. So I think at the moment, I think in India, if one wants to be very safe and you want to get your patients insured, I think you have really two choices, which is ranibizumab, which is Eccentrix, and Eylea. These are the ones that have got the longest clinical trial data. As you know, Kamar Saab said, one of them has been around for 15 years. The other one is now costing 10 years of global availability. So very sure about these products, biosimilars, more and more evidence as it comes. But I think, you know, we're in a great space. I think a lot of our patients do much better than they could ever have done before. So I think, you know, just increasing knowledge amongst people is the key. And we look forward, the oral drugs look really interesting.
Kamar, which is the drug of your choice, Dr. Kamar sir?
Okay, so I still prefer bevacizumab.
Okay.
When I mean I have no other constraint, but in a selected patients I use aflibercept straight away. I don't switch. I straight away go for aflibercept in selected patients. I don't give them a choice.
Okay. And when to be repeated, sir?
Aflibercept for first 3 to 5 months, depending on the indication, you repeat every month. Subsequently, you repeat depending on the outcome.
Okay. And message for anterior segment surgeon, sir?
Anterior segment surgeon. Okay. So you
refer
want to treat?
Refer to retina surgeon.
You want to treat or you want to refer?
We want to refer. When to refer?
Then refer whenever you are in doubt.
Okay. So sometimes patient comes to us, the doctor has advised us anti-VEGF, and we refer to some other surgeon. He says, no, it's not needed. You can continue with a say medical treatment or a tablet antioxidant like that.
So okay, so I mean, if you think from that perspective,
okay,
all these anti-VEGF do not work well when diabetes is highly uncontrolled. If your glycosylated hemoglobin is 9 and above, these drugs don't do well.
Okay.
Because it is a input output. Diabetes creates VEGF. You are trying to reduce VEGF. When you have a highly uncontrolled diabetes, VEGF production is higher than what you can neutralize. So the first and fundamental is, if you are treating a diabetic patient, ask him to have a better control of diabetes, which I mean in a traditional, for Nishant, I'll translate into Hindi, कि तुम दरवाजे खुले रख के छोटी छोटी खिड़कियां बंद करने की कोशिश कर रहे हो. for a diabetic, this is very true. If you are uncontrolled diabetes, if you are uncontrolled hypertension, and you try to give VEGF after VEGF, it has a marginal effect compared to the control of systemic conditions. So systemic conditions comes first. As a matter of fact, I differ. In spite of their insistence, I differ that I won't give you any injections, I won't give you treatment unless you come back to me and show me that you are doing well. You have changed your treatment profile, you have changed your habits, and your glucose control is better, then I will treat you. If you don't want to come to me, don't come to me, but I won't treat you. Trying to emphasize that diabetes control is most important.
Yeah, it's very much important. It's a very good message for us also, sir. Yeah. So I will remember for the life this message. Any comments, Nishan Kumar sir?
No, I think Kamar Saab ke baare mein suna tha, he's a wonderful teacher, but the way he takes complex ideas and puts them so simply is really very, very interesting and wonderful. Inke jo one-liners hain, they are amazing, absolutely. That diabetes control ke bina to kuch aap ek jagah aag bujha rahe ho, dusri jagah aag laga rahe ho. So it, you know, you're just going to go around in circles. But no, absolutely. I think for the anterior segment surgeon, I think the one thing is to be aware about the various options, the advantages, disadvantages, and don't start a treatment because sometimes you want to see the patient treatment naive. Especially in wet AMD, the best time to do a fluorescein angiogram on ICG is a treatment naive. If somebody is already given 2 injections, you lose that ability to identify the disease pathology. So if you're not going to treat the patient till the end, you know, don't get greedy with that 1 injection ka paisa or 2 injection ka paisa or whatever the logic may be. Refer them on so that, you know, that baseline to kind of, you know, treatment idea, the prognosis, the whole explanation can be done correctly. Sometimes when you come in the middle, you don't know where the story started and you don't know where it's going to end. And the other thing I've been taught out myself is that sometimes when you're on a treat and extend regime, you see the patient at say 8 weeks and somebody else has been treating the patient. And the doctor said you need an injection. The patient says a second opinion. The macula is absolutely dry. The fovea is dry. The vision is very good. And you say, why do you need an injection? You don't need an injection. You don't know that the patient has been followed up and there's a certain pattern that's been identified unless you have the whole file, unless you've seen the thought process. Because what will happen is if that patient kind of breaks at 8 weeks, and that's why that 8-week duration has been chosen, you might recommend, listen, nothing needed. Your fovea is dry. Come back again in 2 months' time. In the next 2 weeks, they kind of collapse. Fluid is again. I've learned this the hard way. So always try and see the patient's journey because today a lot of us are doing treat and extend. So don't make a comment till you've seen the patient's journey in completeness. So it's very difficult to nowadays give an opinion based on one visit unless you've seen the old files, the old OCTs and the old pattern. Kamar Saab, your comments?
Yeah. So on the same token, I mean, say there are patients who have been receiving anti-VEGF for diabetic retinopathy and edema for more than 5 years. And if you look at their fundus, you won't find any evidence of retinopathy. But if you miss the injection, then it will come back. So they are maintaining their status because of the injection. So you don't see anything. Patient is very happy, but they need injections. As Nishant rightly said, these are the people who are on the therapy and they need to be on therapy. So anti-VEGF is like an anti-hypertensive drug or anti-diabetic drug, lifestyle management. You have to constantly, only thing is, those drugs are to be taken daily and you go to doctor infrequently. These drugs are to be given by a doctor and at the doctor's discretion.
Okay. Now I think we will move to last lecture. Dr. Nishant Kumar is going to speak on changing paradigms in management of DME. Over to you, sir.
Thank you so much. What a wonderful symposium this has been. Thank you to all of you in Gujarat and especially the Ahmedabad Ophthalmic Society, all Gujarat Society for having me and for introducing me to Kamar Sahab. It's just been so nice to have this kind of a wisdom. You know, this is a learned wisdom. It's like a Warren Buffett. You don't need to talk too much, 2 statements and, you know, puri baat ho gayi. So I'm going to talk about diabetic macular edema. Where is the evidence based? Where do you kind of use these newer drugs that are coming in? And how do you apply the evidence to give your patient the best advantage? That's the kind of talk I want to talk. Financial disclosures, I do a lot of research work. I've been in a lot of clinical trials. So, you know, almost every imaging company and drug company I am associated with either for research or for travel grants. As Kamar Sahab said, this is the most important slide of, I think, the whole talk. Unless you get the systemic treatment right, nothing's going to work. So unless you get the glucose under control, the blood pressure under control, the lipid under control, that's not going to work. So diabetic macular edema, unlike wet AMD, is a multidisciplinary team approach. You need to be in touch with your diabetologist, the dietitian, the nephrologist, if there's a kidney problem. These are very important people who are going to really determine the treatment and the outcomes of a diabetic macular edema. So you can't do it alone. It's not like a sprint race where you're going to do it. This is a team sport, diabetic macular edema, multiple disciplinary team approach. Anything that affects the body is going to affect diabetic macular edema. So if the kidney suddenly starts failing, you get pedal edema, you get fluid retention, your diabetic macular edema will get worse. So all of these things have a very close interplay. So as Kamar Saab said, good glucose control, sometimes telling the patient, I'm not going to treat you till you get your glucose well controlled, is nice. The problem is in Bombay, we lose the patient because there are a lot of doctors who will treat no matter what. But I think in principle, that's a very nice point that you need to get this right. I'm going to start off with the anti-VEGF era because everything else is pretty much a relic. The lasers for diabetic macular edema actually started in the 1970s. The first paper was written in 1977, the year I was born. So, these are older kind of, disease has been known for a long time. And just imagine that even 44 years later, we're yet understanding more about the disease. So we know the laser is no longer the first line of treatment because what was the benchmark for laser? Percentage of people losing 15 letters or more. So there was no question of stabilizing vision or improving vision, is how many people lose less vision, which was not a great benchmark. Then came the steroid era, and there's a lot of evidence that initially there's that great wow factor because the edema completely goes away. But if you look at these people at 2 years, 3 years, the effect does not sustain. Of course, you've got the problems with pressure and cataract. And then came the anti-VEGF, and Kamar Saab has so nicely talked about Macugen, ranibizumab, Eylea, Avastin, biosimilar. There's so many of them, but the clinical trial data is yet very small. If you look at the journals this data is presented in, it's not the A+ journals, it's not ophthalmology, it's not JAMA, it's not retina, it's kind of, some other journal. So the quality of evidence yet leaves a lot to be desired. Rolistuzumab is the new kid on the block, specifically for wet AMD, not yet approved for DME. In their DME trials, they had lots of problems with a lot of inflammation. So it may not be the drug that you want to use because there's some evidence to suggest that any inflammation with repeated injections is a really bad idea. The good news is no matter which anti-VEGF you use, whether it's ranibizumab, bevacizumab, or aflibercept, you're going to get great visual results. For the first time, on average, people are improving by 2 to 3 Snellen lines. That's 15 ETDRS letters. So when you're first time, you're able to say that we will get stabilization of vision in more than 90% of people, and 40 to 50% of people will at least get some improvement of vision, with about 30% of people getting 3 lines on the Snellen, which you would have never done. So the good news is that you've got anti-VEGFs, which are doing a great job on improving vision. When you have a plethora of choices, as Kamar Saab was saying, that the choices are just going to keep increasing, therefore it becomes our job to choose the right drug for the right patient. And I think when you go and see a GP today and say, I have a cough, he doesn't tell you, listen, these are 4 options and these are clinical trials. He says, this is the antibiotic I'm giving you. It could be azithromycin, could be augmentin, could be a penicillin, could be a cephalosporin. But he's making that decision because he's condensed all the evidence and he's making the decision based on the patient in front of him. I think similarly, that's what's expected of us. But it's important to know that in the anti-VEGFs, there's a difference. There's a difference in mechanism of action, in efficacy, in safety, and of course, importantly in India, in cost. Kamar Saab has covered this, so I'm not going to go into it, but Eylea is the only one that works against A, B, and placental growth factor. Why that's important, I'll come to in a few seconds. Just remember, Avastin was never made for the eyes, and if you look at the AIOS and the VRSI guidelines, if you needed to follow those guidelines, it'd be very, very difficult for most private practitioners and even large institutions. I work in Hinduja Hospital. We don't have that lamellar flow grade level 6, which is required according to AIOS. We don't even know where to get it. So it's very difficult to adhere to those guidelines, and therefore medico-legally, it could be a big issue. When you want to compare something, the best thing is not to compare it in humans. Go back to the laboratory, go back to the Excel spreadsheets. Is this drug better? So when you compare the 3 drugs, we know VEGF works on the VEGF receptor 1, that's the predominant receptor. And in the laboratory, we know that it's at least 70 times more potent than ranibizumab against VEGF receptor 1, and about 100 times more potent than Avastin. So that means at least on the starting grounds, on an Excel spreadsheet in a laboratory, this drug should do better because it's much more potent. But when you've got 3 drugs, you want to look at them in clinical practice, the best way to do it is a double-blind randomized controlled trial. We're very lucky to have DRCR network in the US, which looked at diabetes and diabetic eye disease in a new perspective. And this is industry agnostic. They look at all drugs. They're not industry sponsored. So therefore you can kind of rely a bit on their results. So it was a 1:1:1 randomization looking at diabetic macular edema, comparing 3 drugs that we want to do: ranibizumab, bevacizumab, and Eylea. Important to know, they looked at the 0.3 dose. You'll ask me, why 0.3 dose, Dr. Kumar? Well, that's because in the US, 0.3 is what the recommended dose of ranibizumab is for diabetic macular edema. This comes out of the RIDE and RISE trial, which they compared 0.5 and 0.3, and they found that 0.3 was clinically equivalent, but maybe minorly more safe. This 0.3 was never available anywhere else in the world. It was not available in Europe, not available in Asia, not available in South America, not available in Africa, not available in Australia. It was only purely available in the US. But because this was a US trial, they've used a 0.3. But for all practical purposes, we can assume the 0.3 and 0.5 are equivalent. It's important to just try and understand the treatment and retreatment protocol, because this was not a mandated 3 plus Q8 or something like that. It was a PRN. You came in every 4 weeks, and based on certain criteria, you got an injection or you didn't. Now, obviously, if you're coming every 4 weeks, there was no loading dose, if you notice in this. So if you came in and you were improving or you were worsening from the last time, you would get injected. So that makes sense that if you're getting better, try and see if you get even better. If you're getting worse, then definitely inject to prevent that worsening. If there was no improvement or worsening after 2 consecutive visits and your vision had hit 6.6, your treatment could be deferred. That means you didn't need an injection. But that means you had to reach 6.6 for 2 visits, right? If there was no improvement or worsening after 2 consecutive visits and your vision was not 6.8, suppose it was 6.9, then if it was less than 6 months, you yet need to get an injection. But if it was beyond 6 months, then even if your vision didn't hit 6.6, you could defer the treatment. This basically means that they were trying to tell you, please be aggressive with treatment. We're aiming to either get kind of 6.6 vision, which you can't get better than that, or we want to get as good as you can, and we want you to give as many injections as it is possible to get to that benefit. And effectively what this meant is that most people got on average about 6 monthly loading doses. And it's based on this that in Europe, when they kind of launch a drug, the label for Eylea is 5 monthly injections and then Q8. So the posology, if you're in Europe today, is 5 monthly injections and then Q8, which comes from here. Let's jump into the results. The good news is that no matter which drug you gave, Eylea, ranibizumab, or bevacizumab, you got good visual results. The important thing to look at is for patients' perspective is that how quickly does the vision improve, how much does it improve, and does it stay improved? And if you look, even though all 3 of them do a very good job, the orange line, which is Eylea, tends to do a little bit better. This is the graph that created most activity and most interest, because this is the people who had vision less than 612. In average, most of my patients rarely come to me with very good vision. They've had 2-3 opinions. They've sat on it for a while. They've tried some prayers, jari booty, etc., etc. So this is a group I see most often. And in this group, you see that again, the orange line, the Eylea, the vision starts off better, keeps getting improving, and actually ends up better. And this difference was statistically significant, even when you compared Eylea versus Lucentis, which basically gave the whole thought that if you have poor vision, therefore Eylea should be the drug of choice. But this was only 1-year data. Just remember that diabetic macular edema is not a 1-year disease, it's a chronic disease, and therefore even the FDA says that you must have long-term data. If you looked at the whole cohort, you notice that the visual results were kind of sustained over a long-term period, which is very, very nice. If you looked at that group with 612 or worse, again, the visual improvement is sustained. Eylea is yet leading the pack, but that statistically significant difference that we saw at 1 year is no longer maintained between Eylea and ranibizumab. So does that mean that there's no difference? No, not at all. Because this is not a good way of looking at data. All of us who've done some reporting on clinical trials, or even if you analyze your own personal data, you'll notice that you have a lot of missing data. And the way the missing data is dealt with is the last data carried forward, or there are not number of statistical ways. So if one patient has had a bad outcome, it can skew that whole one data point. Therefore, everyone is moving to area under the curve, because it doesn't look at vision at one point, it looks at the vision data over the whole 2-year period. So whether it's the CAT study, the FAME study, All the other studies which are now reporting, they all look at area under the curve because it tells you what happened to those patient cohort over a 2-year period rather over one time point. And that's the best way to look at data. And if you look at the area under curve analysis for the same data of DRCR network at 2 years, what you find is that aflibercept did much, much better, 17.1 letter improvement compared to ranibizumab 13 and Avastin 12. And this was statistically highly significant for both when you compare Eylea to ranibizumab or Eylea to Avastin. And actually, that's not just statistically significant, that's almost 5 letters on ETDRS. So that's 1 Snellen line. So that again becomes clinically significant as well. So if you look at this data with kind of a more modern understanding of how you should look at data, which is area under the curve, looking at what happens to the patients over long-term time, you notice that patients on Eylea tend to do much better. Anatomical outcomes, as Kamar Saab showed, that Eylea does dry it up a bit better, but this is statistically significant in both 1 and 2 years. I want to share some new data with you. We're always looking at people who had kind of 6/12 vision and a very bad looking macula, lots of thickening. For them, of course, Eylea was the drug of choice and it tends to do much, much better, as that graph shows, the blue line. But what if your vision is worse, but you don't have that bad a macula? There's not that much swelling fluid. Even then, Eylea is the drug of choice because it tends to do much better. In the study, you notice that people were allowed to have laser rescue therapy after 6 months. So the proportion of people needing laser was much less in the Eylea group than the other 2 groups, both at year 1, year 2, and overall. And this is again statistically significant. What about the number of people who have persistent DME? Again, if you look at that kind of 12 and 24 weeks, which is 3 months and 6 months, you find that people who had persistent macular edema was much less in the Eylea group, which is the blue line, compared to kind of bevacizumab and ranibizumab. So again, people who had persistent edema, much less. And that was statistically significant. The proportion of people gaining vision at 12 weeks was much higher. If they gain vision after the first 3 injections, they're likely to continue with their treatment because they notice that improvement. So 10 letters or more, which is 2 Snellen lines, much more in the Eylea group. What about the percentage of people losing vision? Much less in the Eylea group than the other 2. So that's an ideal drug. A lot more do better, a lot less do worse. If you look at the kind of protocol T, after 2 years, they kind of gave them back to their doctors and said, listen, follow up with your doctors, no particular protocol, treat it as per clinical need and as per the discretion of your doctor. The good news is that over a 3-year follow-up, so 5 years, you yet are doing better than baseline. Your yet vision improves by more than 1 Snellen line, almost 2 Snellen lines, but that improvement is a little bit less. Why is that? Let's look at that. So if you look at it over a 3-year period, the median number of visits was only 12 and the median number of injections was only 4. Now, this is the US. Just remember that out here, there's no cost for injections. They all are covered under Medicare if you're diabetic. So it's not a cost that's the issue. It's either patients not coming back for injections or doctors not treating aggressively. Cost is not an issue here. So even in developed countries where cost is not an issue, under treatment is a big issue, and under treatment leads to that loss in vision is what I wanted to show you. This is one of my favorite graphs. This is the RESTORE study. This has nothing to do with Eylea. This is a Lucentis-based study. All of us know that you give 3 loading doses with Lucentis. So what happens if you gave the first injection, the second injection, third injection, and instead of vision getting better, it actually got worse. 1 Snellen line worse. Most people at this stage will start thinking, should I add a steroid? Should I kind of change the drug? Should I do some vitrectomy and ILM peel? Should I do something else? Should I refer the patient to somebody else? In the RESTORE study, that wasn't allowed. So what they said is you just continue treating as per protocol and just look what happens. If you just continue treating as per protocol, at 1 year, their vision does switch. So suddenly they switch and they start responding. At 1 year, they had 8.8 letters. At 3 years, they had 11 letters, which is like more than 2 Snellen lines. So don't get excited if initially the reaction is not what you expect it to be. Please continue doing the same anti-VEGF treatment and you see a majority of patients will swap. A lot of doctors ask me, Dr. Kumar, what can we do? Can you hear me?
Yeah, go ahead. We can't hear you anymore. You are frozen.
So a lot of people say that how many injections should we really give improvement? After the second Snellen line, after the third injection, and after the fifth injection, 14%. Half a second. Can you hear me now? Can you see me now, Kamar sir?
Yeah, now
Hello?
it's okay. Go ahead. Go ahead.
Sorry, I don't know what happened. So the Vivid and Vista trial was another ILEA trial, which basically showed us that if you continue to inject at least 5 injections, the percentage of people who continue to improve by more than 5 letters, which is 1 Snellen line, is quite large. Even after the 4th injection, 15% of people improved again by 5 letters. So if you limit your treatment, say, I'm not going to treat aggressively initially, you're going to miss a lot of that proportion of people who can continue to improve. And that's where the Vivid and Vista trial said 5 monthly injection. That comes from this graph, that even despite 4 injections, 15% yet got more improvement in vision. And therefore, the Vivid and Vista European study said, please continue to inject. This is again from protocol T. Effectively, if you think about your diabetic macular edema patient, you can divide them into 3 categories. If you look at the dark blue line, they're the A+ student, they're the Usain Bolt. They start off very quickly, they do very well, they increase very well, and they stay very well. And over a 2-year period, they're fantastic, 18 letters, which is 4 Snellen lines, which is incredible. The light blue line is like a good student. He's like an A student. He's not A+. He improves, he stays there, and he stays improved. 10 letters, so that's 2 Snellen lines. Look at that third line. This is the red line. These are the late bloomers. You gave 1 injection, nothing happened. You gave a 2nd injection, nothing happened. You gave a 3rd injection, also nothing's happened. The vision is at baseline or slightly below. What do? Don't change. Continue with your anti-VEGFs. Look at how they do. They all pick up, and on average, they get much better, 6.2 letter, more than 1 Snellen line. So just remember, don't swap too early, don't change too early. We all know that there's a disease-modifying effect of anti-VEGFs, particularly of ILEA. And why is this important to us? Because 30% of people with DME have PDR, 40 to 50% of them have severe NPDR. And therefore, if there's a disease-modifying effect and you can deal with not only the macular edema, but also the severity of diabetic retinopathy, that'd be wonderful. So new data I want to share with you. I'm going to talk about this perfusion. This is something new that is going to be unique to all of you, I hope. Is that what the Vivid and Vista did is that they all had fluorescein angiograms done. They divide the angiogram into 4 quadrants: above the superior arcade, below the superior arcade, nasal to the disc, and temporal to the disc. So the macula came in the temporal to the disc, the superior, inferior, and nasal. And they tried to see that is there any improvement in perfusion. So it's very binary. It wasn't measuring it. It said, okay, how many quadrants have non-perfusion? So there are any areas of capillary loss? That was, yes, there is non-perfusion. And is there an improvement when you treat them on ILEA? And what you notice out here that at kind of 6 months, 30% almost got an improvement in perfusion, at least 1 quadrant. And if you looked at it at 2 years, 44% got an improvement in perfusion. That means that there was at least 1 quadrant which showed baseline non-perfusion. And again, when you looked at them at 2 years, that reperfusion had happened completely. That's not really been seen that often. We do see some remodeling, some reperfusion, but a complete reperfusion is something that's unique with ILEA according to the study. So significant improvement. Let's look at just the macular area, because we're not so worried about the rest. We're more worried about the macular area. Please note, this is not foveal avascular zone. This is the whole macular area that we're looking at. But if you looked at just the macular perfusion, if at baseline there was no perfusion or there was some disruption of perfusion in the macular area, at 2 years, 50% of them showed complete reperfusion of the macular area. So 50% of them completely reperfused their macula with ILEA treatment. Now you might say, Dr. Kumar, that's the natural history of the disease. That has nothing to do with drug. But luckily in these studies, in the Vista study, there was a laser arm. So if you look at that kind of blank white bar, that's the natural history. So if it was natural history of the disease, then all of them should have had the same result. It's 16% versus 50%. So there's not natural history. There is definitely an effect of the drug happening out here. 50% of them showed complete reperfusion of the macular perfusion. But the important thing is that does it affect vision? So if you look at this, traditionally, even when I was kind of a student, a fellow, and then a consultant at Moorfields, we always said if there's non-perfusion, it's guarded prognosis. Is that true? Let's look at it. If there was non-perfusion noted at baseline in the temporal area or in the macular area, look at the improvement of vision with ILEA, yet very good, 13 letters. And if there was no macular non-perfusion, they also did very well. So if there was some non-perfusion in the macular area, don't tell your patient they might not do well, because you might be surprised with the anti-VEGFs. Reperfusion may lead to better visual outcomes than you initially expected. Let's look at reperfusion. Supposing that reperfusion occurs in the macular area, then of course the visual results with Eylea are fantastic, 17 letters. But even if there's not complete reperfusion, yet you get 15 letters. So that initial dictum that reperfusion may not happen and therefore visual results will be bad is not necessarily true. If it does happen, of course, great. If it doesn't, also your visual results can be wonderful. If you looked at PDR, as Kamar Saab showed us, that a bigger percentage of people with Eylea got a much better kind of response to their PDR than any of the other two drugs, which is statistically significant as well. Clarity study is a study done in Moorfields when I had left. They found that if this is comparing Eylea versus PRP for PDR, and of course with Eylea, 64% got a complete regression of their neovascularization compared to only 34% with PRP. So again, showing that huge disease modifying effect of this drug. Just quickly to take you through some real world experience. In France, this was an observational study. And what they found is that if you used Eylea in routine clinical practice, in treatment-naive patients, you got a +8 letter improvement compared to +5 they were previously treated, which is again 1.5 Snellen letters. This is real-world evidence. If you followed the 5 monthly doses, you almost got 2 Snellen lines because it was +9 letters. And if you look at the number of injections, it wasn't that different. So treating aggressively initially definitely gives you an advantage. This is a study close to my heart. It's my alma mater. I was a consultant here. I was a fellow here. I spent a lot of years at Moorfields. So I can tell you about Moorfields that 30% of the people are all Asian, which means Pakistani, Bangladeshi, and Indians. And this is people walking through the door with stupidly high HbA1cs, poorly controlled diabetes, kidney disease, heart disease, hypertension. So this is not a self-selected group. This is kind of the Moorfields real world data. The only difference is that they all got 5 monthly loading injections. And just look at this. If your vision was less than 612, 13.8 letter improvement, which is 3 Snellen lines. Unimaginable. And this is real world data. This is people walking through your clinic. And if you looked at the number of people who improved vision, about 50% got 2 Snellen line improvement. This is normal people. This is Afro-Americans, Pakistanis, Bangladeshis, Indians, who are going through this. So the number of injections was 7.4 in the first year for such wonderful results. If you looked at the same data over a 3-year period, over 3 years, that improvement was maintained at 11 letters for people with 612 or worse. And look at the number of injections. In the first year, aggressive treatment because 5 monthly loading doses only. Second year, hardly 2.7 injections, so less than 3. And third year, also less than 3. So with 11 injections, you could get great results. And what I've used this data to tell my patients that do very well. Because the first year you're going to give a lot of treatment program, it really helps us kind of counsel patients as to what to expect. And on average, if they can take about 10 to 11, well. This is the Australian registry. Kamar Saab already showed the meta-analysis, which again is very convincing that if you looked at Eylea versus bevacizumab versus ranibizumab, the chance of you getting a 3-line improvement is much higher with Eylea than it is with the other two drugs. And you look at that confidence interval, a Cochrane meta-analysis basically looks at all the data, looks at the quality data, puts it all together, and tries to give you a summary of what is the current evidence. So this is the strongest, highest form of evidence that there could be. So if laser had a 10 chance of giving you 3-line improvement, with Eylea, that was almost 36. So much higher chance of improving vision. If you just compare the 3 drugs, much higher chance with Eylea of you improving your patient's vision in diabetic macular edema by 3 lines. And if you looked at the visual results, plus 10 letters over kind of a year with Eylea compared to plus 6. So almost double the kind of effect in a meta-analysis. If I show you this data slightly differently, of course, laser versus Eylea, you expect Eylea to do much better. But even ranibizumab versus Eylea, again, you get almost 1 Snellen line better. And today the costs are not that different. So it's a much more potent drug. Placental growth factor is a key out here in the disease modifying effect. I think there's a lot of new evidence to suggest the placental growth factor has a huge role in diabetic macular edema and diabetic retinopathy, particularly in reperfusion. And I think that's why this is one drug that's doing some really wonderful things with reperfusion. We don't yet fully understand it. We know for a fact that multiple factors involved, but placental growth factor, VEGF-B, VEGF-A, and a number of other factors are most probably involved. But this is one drug which has showed such remarkable change in reperfusion, which we've never seen before. It's statistically and clinically better than the other two available drugs to us in the country today. Significant impact. Most of our patients have bad diabetic macular edema and bad diabetic retinopathy. When they come to us, as Kamar Saab said, that because you start treating them and you see no diabetic retinopathy, don't think that this patient is being treated for nothing. It's a drug that is reversing the diabetic macular edema so nicely. Real world evidence very rarely can keep up with the clinical trial evidence. We always see a disconnect. It's for the first time that a lot of real world evidence is showing that the drug is performing just as well as clinical trial data. And when you have a meta-analysis, then that just kind of cements it that this is the drug of choice. I'll just leave you this Gujarat. I run a charitable foundation. It's been around for the last 3 years called IBTs. It's a passion I have because when your eyes have diabetes, you have IBTs. So Kamar Saab, please, I expect you to kind of spread this word. Aap itne achhe jumle bol dete hain. So IBTs is what we're talking about. We've got 3 Guinness World Records for our charitable work. We've seen about 110,000 people for free with our charitable foundation for diabetes-related eye disease. Sachin Tendulkar and all of these people are our brand ambassadors, and we're really trying very hard to spread awareness that diabetes blinds, because I think even amongst diabetics, that awareness is very, very poor. Even among ophthalmologists, the awareness about the newer drugs, the way we can save vision is very, very poor. So I think there's a lot of work in advocacy to be done. And thank you very, very much for inviting me and having me here.
So thank you very much, sir. It was a very much informative and exhaustive study about your diabetic management study. Dr. Kamar, sir, any comments?
Okay. So Nishant, thank you for coining the word IBT. I think we should spread it through AIOS.
Ji, bilkul. I am working with Natarajan and the rest of the group. Of course, everyone is doing their own bit. You know, we are trying our own bit, and you know, boon boon se sagar ban jayega ek din.
No, but the challenge is, see, what is happening in India and what is happening around the world is there is a little disconnect. We work as an individuals. We don't work as a group. Okay, so if AIOS as a group says that, okay, we should work against diabetes eye disease, it makes sense.
Absolutely. Absolutely, sir.
So, I mean, that's what I say. I say we have to be part of a team rather than each individual, because team can always bring better results than individual. So, but it's a nice coined word, worth resonating multiple times. Okay. Now, I mean, on the lighter side, I mean, is there an effort? I mean, I don't see significant effort to define efficacy of a drug based on a phenotype and promoting it in that way. Because each phenotype, though it is part of a big umbrella, has a different underlying pathogenesis. And I don't see any effort. And then there is a correlation with the systemic comorbidities.
True.
So these are all known factors. These are all have their own particular nuances. But I don't see the connect between all of them. See, and this is probably what the next disruptive will come from. Because if I treat everybody the same way, I will reach a particular level. And what I say to whomsoever I can say is that anti-VEGF is a paracetamol for fever. Unless you give antibiotic, unless you treat the basic pathology, because it's not like a viral infection which will go away on its own.
True.
So unless you treat the basic pathology, you are not likely to see significant improvement in whatever we are seeing today. It's good to control the fever. It's good to keep the fever under control so that you can work normally. But you are not going to get rid of the disease. And unless you get rid of the disease, you are not going to be better off.
I completely agree, Kamar Saab, you know, and I think it's such an incredible thing, Kamar Saab, that this disease has been around for a long time. We thought we know how to deal with it, but actually we don't, because if you think about it, the phenotypes that you said, initially people started saying, listen, if you're seeing these chronic cysts, you're going to kind of, treat them with steroids. And then now we see that even with anti-VEGF, they do very, very well. And you might not need a steroid with kind of Eylea treatments. I've seen these cysts disappear very quickly.
See, the
So
advantage
I understand.
So the advantage Eylea offers is over others is it has dual action. It is potent anti-inflammatory plus potent anti-VEGF, while all others are anti-VEGF.
Absolutely.
That's where they suffer.
So please conclude the session.
Okay. So Nishant, you were the last, so conclude the session. Okay, go ahead. It's only three of us. Yeah.
Yeah.
Thank you, Rana Saab. I think Prashant had to leave because he had another talk. Thank you, Kamar Saab. It's been a pleasure and a privilege to be with you all. I hope this session has been informative. I think, we think of diabetic macular edema as the non-sexy because there's so many other nice terminologies, PAM, AMN, etc., etc. But this is really our bread and butter. And I think as a country, we are seeing more diabetic macular edema than anything else. So this is going to be our bread and butter. There's a lot of great stuff. As Kamar Saab said, incremental changes one day might lead to disruptive changes. But at the moment, we must keep ourselves aware of the new evidence, aware of the new drugs. And I think we have to be lucky and thankful to pharma and to at least a lot of the Indian government that as soon as a drug is launched globally, now we somehow get it in India at a price that is yet affordable. It's not that it's costing 1.5 lakhs per injection, which means that it's unaffordable to everybody. But I think lots of work on diabetic macular edema yet to be done. Some very, very interesting insights by Kamar Sahab. And I think the number one takeaway for a general ophthalmologist is refer the patient to the diabetologist first. Get that diabetes controlled first. Don't take out your injection first. Refer them to a multidisciplinary team. Get that diabetes, lipid, cholesterol sorted because that is the biggest favor. That is the best treatment you can give them. And then after that, if you can, please refer them on to a good retina specialist. In COVID, hamari halat kharab ho gayi hai. We're not doing that many surgeries, so we need your support. No, but a joke aside. And the last thing is that, that we need the support of Gujarat because there are two Gujarati gentlemen who can spread awareness about diabetes and blindness. At the moment, he's talking about a lot of other things. Hamare Dadi Wale Baba, who we all respect and love a lot, our Prime Minister. I am trying very hard with my limited resources to create a lobby that the next project for him should be diabetes and blindness. He looked at polio and look what has happened in India. We eradicated polio. We're looking at TB. And I think a great amount is being done with Amitabh Bachchan and so many other brand ambassadors. Our national level awareness about diabetes and blindness will come from Gujarat only. So Kamar Saab, Rana Saab, aapko hi push karna padega.
Done, sir. Okay. So here we conclude the session and we'll switch over to the next one. I think there are still 6 minutes left if you want to discuss anything. Or otherwise we'll leave. Come on, sir.
Okay. So, I mean, this is not relevant. So, Rana, we should stop here. But if Nishant wants to discuss something at a personal level, I'm available. Okay, Nishant.
Ji, sir, aapko main phone karunga. I think this is being streamed live on YouTube. So, so people might think, what happened to Eylea and evidence-based medicine? So, I'll definitely reach out to you. But it was wonderful. And these kind of symposiums are fantastic. It really kind of helps us learn so much.
Okay.
Thank you, Rana Saab. Thank you, Kamar Saab.
Thank you. Yeah. Okay. Thank you, sir. Bye, sir. Bye.
Good morning, Dr. Ashish.
Yeah, good morning. Good morning.
Sir, there is a little change. I want to request you to let me substitute for Dr. Aditya Sethi. He's actually gone for something really important.
Of course, sure. Go ahead. We still have time. 10:30 we'll start.
Sure, sir. We'll start when required.
Hello, good morning, Dr. Ashish.
Good morning, Dr. Shalini.
How are you?
Great. I'm good. How are you?
I'm good.
Everybody's here. Great.
Yeah.
Good morning, Dr. Chudani, sir.
Good morning, everybody.
Good morning, Dr. Manilal. Good morning, Dr. Khamer.
Good morning.
Good morning, Bogavai.
શું ખબર છે?
બસ મજા.
શું કરવાનું છે તું આજે? અરે પાછળ વાઘ રાખે છે?
સિંહ છે. અમે વાઘ રાખીએ, સિંહ રાખીએ.
બીજા ખબર કે બધું બરાબર?
Okay, all well.
almost 10:30, 10:28. Dr. Shalini, you are first. Would you like to go ahead and test your slide?
Okay.
Hi, Dharmesh.
Yeah, I will check.
Good morning, sir. Hello.
Hi.
Good morning.
Are my slides visible?
Yes, ma'am.
Okay, thank you.
Sundays is conference day. From all India to state. I think at the outset, I would like to welcome everybody on behalf of the Gujarat Ophthalmic Society. Thank you for taking out the time. And I think this is a interesting mixed bag session. So we'll have a mix of different specialities. And, so I think in keeping with the time, I would like to request Dr. Shalini Mohan to inaugurate this session.
Yeah. Shall I start? Can we start our program? I think it's almost 10:30. Yeah, okay.
Please,
so I will start with my presentation as I have my first talk. Is my screen visible?
Yes, ma'am, we can see it.
Okay, thank you so much. So I'm going to talk about ocular blood flow. Does it really increase? Well, we all understand that glaucoma is basically chronic glaucomatous optic neuropathy, where we have corresponding visual field defect, and raised intraocular pressure is the most important and the only modifiable risk factor. But many a times what we feel that despite achieving target intraocular pressure, our patients, they keep on progressing. And that is why the idea came to our mind that there is something else besides this raised intraocular pressure. And this was seen in various randomized controlled trial also, like early manifest glaucoma trial, collaborative normal tension glaucoma study, and normal tension glaucoma study, that despite control of intraocular pressure, several subset of patients, they kept on progressing. And here comes the role of other risk factors like ocular perfusion pressure and ocular blood flow. Now, when we talk of ocular blood flow, we understand that optic nerve head ischemia has led to induction of retinal ganglion cell loss that is independent of intraocular pressure. Also, reduced perfusion renders these glial cells more susceptible to pressure-induced damage. Thirdly, lower diastolic velocity and higher resistivity index in various arteries, in various retrobulbar arteries, is associated with increased risk of visual field progression. And also, reduced diastolic velocity in central retinal artery has been associated with progression of glaucoma. Well, with these points in mind, we will see this consensus series from World Glaucoma Association, where they also said that lower blood pressure and ocular perfusion pressure are associated with higher glaucoma prevalence and increased incidence along all racial groups. Second important factor they said is that reduced blood flow is directly associated with visual field loss. And thirdly, they said that vascular factors, especially ocular perfusion pressure and blood flow, are gaining prominence as a major contributor to optic neuropathy. When we say reduced ocular blood flow, let's see what are the various causes. Vasospasm or vascular dysregulation, defective autoregulation, low or fluctuating blood pressure, atherosclerosis or autoimmunological diseases, diabetes, and finally, these reduce ability of eye to adopt to this normal or abnormal IOP, and subsequently to blood pressure leads to reduced ocular blood flow. Now, when we see there is various kind of Valsalva maneuvers which keep on happening in patients' lifestyle, they also tend to reduce the ocular blood flow. So we did a study at our center where we studied the effect of Valsalva maneuver on glaucoma patients. And what we found that there was reduced peak systolic velocity and diastolic velocity, an increase in resistivity index in all such subset of glaucoma patients and this actually correlated with mean deviation of our patients. So the question arises, can we improve this ocular blood flow? Second thing which comes to our mind is, can we modify the ocular blood flow parameters? Can medication increase the ocular blood flow parameters and thus help our patients? So when we say that do medications play a role? Now, certain ocular hypotensive agents, they may improve the blood flow like bijaxilol, latanoprost, bimatoprost, but these primary findings are basically not due to increase in the ocular blood flow independent of IOP reduction. But then carbonic anhydrase inhibitors, they have shown to increase red blood cell velocity in normal individuals as well as in patients of glaucoma. And this positive effect on ocular hemodynamic has been observed with other, whatever has been observed with other anti-glaucoma medication is more than what's seen in carbonic anhydrase inhibitors. So this was emphasized by our World Glaucoma Association also. The topical carbonic anhydrase inhibitors, they enhance the ocular blood flow independent of their hypotensive effects. So these are various controlled studies, and there was a meta-analysis also which analyzed almost 28 studies, and they found that the carbonic anhydrase inhibitor, they tend to increase the ocular blood flow. We also did a study on carbonic anhydrase inhibitors in our subset of glaucoma patients, and we also observed that carbonic anhydrase inhibitors, they tend to increase the ocular blood flow. Now we have ROCK inhibitors, which increase the outflow vacility and therefore decrease intraocular pressure. And they have also found to increase ocular blood flow and prevent the retinal ganglion cells. Now coming to, these were the topical medications, and now coming to systemic medications which increase the ocular blood flow, like antihypertensive medications. We know that calcium channel blockers, especially the centrally acting, they increase the ocular blood flow. Then ACE inhibitors, they are also, they have found to increase the ocular blood flow and decrease the IOP. In Rotterdam eye study, it was seen that females on hormonal replacement therapy and postmenopausal are at lesser risk of developing glaucoma. And then nitric oxide synthetase reduces the choroidal and optic nerve head blood flow. And now we have prostaglandins analog, which are liberating nitric oxide also in our armamentarium. Now, what about other drugs or compound? It is important to understand that it has been found that ginkgo biloba has found to increase the ocular blood flow. Now, there are other certain antioxidants which have seen to increase the ocular blood flow, and especially like magnesium, antioxidants, vitamin B, flavonoids, and they have found to increase the ocular blood flow. But there are so many confounding factors on this because modality of measurements. Like there are variety of measurements, especially we tend to do this Doppler study at our center, And now we have OCT angiography also, which can actually quantitatively and qualitatively measure the ocular blood flow. So probably this confounding factor on modalities might be taken care of. Then there are other factors like age, atherosclerosis, hypertension, diabetes, migraine, reduction in intraocular pressure simultaneously, and then concurrent anti-glaucoma medication, which may act as a factor in improper measurement of ocular blood flow. So these are various fallacies that we don't have any definitive data to show that despite improving ocular blood flow, does this actually protect the long-term visual acuity in our patient? Secondly, does this increasing ocular blood flow actually enhances the visual fields of our patients? So we need a long-term prospective control trial to prove this data. To summarize, I would say that ocular blood flow is useful to get an insight into pathophysiology of glaucoma. Now, blood flow measurements may be useful as an independent assessment of glaucoma severity. There are various maneuvers which can reduce the ocular blood flow and can lead to progression of glaucoma, like Valsalva maneuver. And therefore, we need to ask the patient not to do these maneuvers. But then further studies are definitely needed to see the long-term potential avenues of therapeutic intervention by enhancing the ocular blood flow. Thank you so much for your kind attention.
Thank you so much, ma'am. I think just like Valsalva, I think with COVID, no sneezing, no coughing, nothing allowed, I guess, for us, all of us.
Yeah. Yeah, definitely. And in fact, the study we did was on one of our priest of a temple who was continuously blowing conch shell in the temple during aarti chanting in morning and evening. So his glaucoma was progressing despite controlled intraocular pressure. So we gained this insight from that particular individual, and then we did this study on Valsalva maneuver. And it was actually a very good study in which we saw that there was increase in intraocular pressure, and simultaneously on color Doppler, we could measure that there was decrease in the peak systolic velocity and in diastolic velocity. So that gave a good insight into these subset of patients. But obviously, effect on visual field still needs to be analyzed in our patients.
Then in that case, I think post-COVID, a lot of people are undergoing the doing exercises to improve the lung capacity and other things. So they may also indirectly have impact.
Yeah, probably. We should actually go and do these studies, and especially because of OCT angiography, probably analysis would be easier in these patients because color Doppler needs a dedicated radiologist to do this study. So probably, I think that's a great idea, Dr. Ashish, and we need to incorporate this in our research thing.
Thank you so much, ma'am. I think the next speaker is Dr. Shikha Basi. She's there. Yeah. May I request you to, you can share your slides.
Yeah, sure. Good afternoon, everyone. Please share my screen.
Good morning from here.
Am I sharing my screen?
We can see.
Can you see my screen?
Yes, ma'am. We can see your slides.
Yeah. So at the outset, I would like to thank the organizers, especially Dr. Priya Naran, for giving me this opportunity to talk about optic neuritis in MOG-AD. So what is MOG-AD? Myelin oligodendrocyte glycoprotein antibody disease. It's a subset of neuroinflammatory conditions where antibodies to MOG are present, and it expresses as a clinical phenotype which is distinct from multiple sclerosis or from neuromyelitis optica. Now it presents with optic neuritis. Like other neuroinflammatory diseases like MS and aquaporin 4 Ig disease, optic neuritis is the most common presenting feature of MOG-AD as well. It occurs in around 54 to 61% of patients. So how do we differentiate between the optic neuritis of MS, NMO, and aquaporin 4 disease? Now, when the first attack of optic neuritis occurs and it's not disseminated in time and space, it's called clinically isolated syndrome. If it relapses, then it can be either of the three. That is, it can be either multiple sclerosis, it can be NMO spectrum disorder disease. These two, MS and NMOSD, are characterized by typical features on the MRI brain. If the MRI brain is normal and patients getting recurrent attacks of optic neuritis, you call it prion. Now, in NMOSD, now where does MOG optic neuritis fit in? It fits in here. So NMOSD has two clinical spectrums, that is one of MOG-AD and the other is aquaporin 4 IG NMOSD. Now, it's very important to differentiate between the two because the prognosis is different in these diseases. How do you differentiate between the two? In MOG-AD, the cause of optic neuritis is primarily demyelination, whereas in AQP4, it is secondary demyelination. MOG-AD is triggered by vaccination and infection, whereas aquaporin 4 disease, it's a water channel astrocytopathy. MOG-AD is equally distributed in males and females, and there's no ethnic predilection. And aquaporin 4 disease is 9 times more common in females. It's seen more commonly in Asians. MOG-AD is seen more common in children. At this point, I would like to add that during this COVID-19 pandemic, because it's triggered by vaccination and infection, we are seeing more number of MOG optic neuritis. Now, other than optic neuritis, what are the other CNS features of MOG-AD? It can cause myelitis, encephalitis. It can cause acute demyelinating encephalomyelitis, that is ADEM, which is seen more commonly in children. Now, coming to the MRI features of MOG optic neuritis, it tends to occur bilaterally in 50% of cases. And it typically causes long lesions in the anterior intraorbital optic nerve. And there is typically there is perineural sheath involvement, because of which on MRI, the perineural sheath appears prominent. What are the antibody tests available? How do you confirm this? Live cell-based assays can be done. Immunofluorescence, Western blot and ELISA are the other ways with lower sensitivity and specificity. Of all these live-based, cell-based assays are, though very specific and sensitive, they're very expensive, and it takes time for the reports to come. What are the MRI features in the brain? You get to see poorly demarcated, fluffy white and gray matter lesions. And it can also present as diffuse leukodystrophic like white matter changes. Here you can see these lesions. Coming to the treatment, the early treatment with IV steroids definitely gives a better prognosis. You need to taper the steroids more slowly. And if you add prophylactic immunosuppression during the tapering of steroids, it helps in preventing the relapses. And if the patient's not responding to IV steroids, you can consider plasmapheresis and immunoglobulins. Let's look at some cases of optic neuritis. This 30-year-old female has come with decreased vision in the left eye, and fundus examination showed bilateral disc edema. She has dense inferior field defects in the left eye, some milder defects in the right eye. She has a signal in both her optic nerves, and what we're seeing here is typical features of multiple sclerosis on the MRI. So what she was treated with the intravenous methylprednisolone, and the optic neuritis resolved. Her visual fields have cleared up, disc edema has cleared up. So this is a typical optic neuritis associated with MS, which has been very vastly studied with ONTT trial with a huge follow-up of 15 years. So whereas MOG IG disease is a recent advance, it has been of late only we have started diagnosis MOG optic neuritis. So in the subset of 177 patients who are still following up with ONTT, when they did the MOG IG test, 3 patients tested positive. None of them tested positive for aquaporin 4, but 3 tested positive for MOG IgG. And what is important is that none of them developed multiple sclerosis at 15 years. So it's very important. They were being called, MS patients who have not progressed further, but it was actually MOG IgG. Now let's look at more Coptic neuritis. This 19-year-old boy presented to us with bilateral decrease in vision. He had no history of COVID or any other recent viral illness, but he had a history of vaccination. He presented with dense central defects in the right eye and left eye mild defects. The MRI showed a signal, T2 hyperintense signal in both the eyes. He was tested positive for MOG. He was treated with intravenous methylprednisolone. Immediately, he had a good visual recovery. But the OCT showed loss of GCC in both the eyes and significant changes in the RNFL layer also in both the eyes. So the treatment option for him was slow tapering of, after the intravenous steroids, slow tapering of steroids, and addition of oral immunosuppression at this time also can be discussed with the patient. Let's look at another case here. This 32-year-old female presented to us with recurrent attacks of left optic neuritis. You can see that the sheath on the left side is a little prominent, and she also tested positive for MOG. So the treatment option for her is, I'm sorry for the spelling mistake, injection rituximab. Now, we've also seen unfavorable responses to the treatment with MOG optic neuritis, though typically these patients respond well, but these unfavorable responses have been reported. We've also seen in this 71-year-old female, she came to us with insidious progressive loss of vision in both the eyes. Her visual fields was grossly constricted, and she did not respond well to intravenous methylprednisolone. She was started on Mycet and oral steroids. So to conclude, MOG AD is more common in children, and the optic nerve sheath is involved. Fluffy brain lesions can be present, and as ADM is more commonly seen in children, and it responds well to steroids, but you need to be careful about tapering the steroids slowly. Thank you.
Thank you so much, ma'am. I think I just had one question. Do they require prolonged immunosuppression, ma'am, in the children?
It depends on the treatment protocols, I'll say, are not very clear, not very well defined, but you need to see how often the patient is relapsing. See, even after the first attack of optic neuritis, you slowly taper the steroids. Along with that, in the institutes where you're getting referral patients, we start off the immunosuppression also, because they are known to, if the patient has come out to be MOG positive, they're known to relapse. So we start oral immunosuppression for these patients. And which can, if the patient stabilizes, can be after a while, patient needs to be under a care of a neurologist as well. It can be over a period of time stopped as well.
That was a very interesting case presentations, Dr. Shikha, and we actually learned a lot. Now, I also wanted to ask you that what immunosuppressants do you prefer in these subset of patients?
See, I showed you 3 cases and I've used 3 different immunosuppressives.
Exactly,
just wanted to put across the spectrum. Usually oral, just like other cases of NMO, where azathioprine, oral azuran remains the first choice of drug. And where you're getting recurrent relapses, you've been using IV methylprednisolone, their injection rituximab can be given. And elderly patients, Mycet is a safer option. Mycophenolate, no.
Yeah, Morphitin, yeah. Thank you so much.
Okay, thank you so much, ma'am. Thank you so much for sparing your time. And now I'd like to request the next speaker, Dr. Dharmesh Shah.
Yes, sir.
Presentation. And I'll also request him to moderate the rest of the session, as I may need to go to another hall in a few minutes.
Sure, sir.
Hear your talk and go.
So this is actually a mixed bag session from north to south to west, from glaucoma to optic neuritis. It's a wide variety of topics. So just to give a brief this thing about SLED, going from the why is SLED needed? Why is the limbal transplantation needed? Because there is limbal stem cell deficiency. It can be because of most commonly traumatic, that is the chemical or the thermal injury, and sometimes due to autoimmune diseases like SJS and OCP. Also in severe long-standing VKC, we can have limbal stem cell deficiency. So what happens is, this is an actual schematic diagram showing how the limbal stem cells work. There's a limbal niche near the, in the palisades of Vogt at the limbus, and they differentiate by mitosis to form a transient amplifying cells, and that they in turn go on to form the corneal epithelium, and they become more differentiated cells. So this is actually compared with the planting of a tree, where the soil and the substrate is the amniotic membrane, the seeds are the epithelial, the limbal and the ocular surface needs tears as well, like rain. So earlier we used to do CLAW and CLED, that is the conjunctival limbal autograft. That is, we take 2 claw covers of the superior and the inferior conjunctiva along with limbus, and we suture it accordingly in the recipient, this thing. But then CLET was the game changer, that is the cultivated limbal epithelial transplantation. What we did was, we took the limbal stem cells of the healthy donor eye and cultivated it on an amniotic membrane in the laboratory. And when the amniotic membrane was having cultivated limbal stem cells, we used to transplant it into the recipient eye. So this was having very good results, especially in chemical injuries, but it involved expense and the state-of-art laboratory. So it was not useful for all. So in 2012, Sangwan et al., our own pioneer of SLED from India, who taught the world how to do SLED, he introduced limbal epithelial transplantation, and he showed to all that limbal stem cells transplanted on the cornea replenishes the epithelial cells and makes it clear. It has advantages of both CLAW and CLED, but minus the limitations of lab and expense. So it was universally accepted by all. It is auto-SLED for unilateral cases, the donor eye being the other eye which is healthy. But in bilateral cases, we have to do SLED from the living related donor, and they may need immunosuppression for a long time. And allo-SLED is also done from cadaver, but that is in acute stages, not for visual restoration. So we will not go into detail. But this is a must-read article for anyone who wants to know the ABC of SLED. This is a very good article from the LVP group headed by Dr. Sayan Basu, and it shows how the SLED should be done, when it should be done, and when should it not be done. So looking at the article itself, the top 4 pictures of the first row, they are the ones who have pannus, they have severe limbal stem cell deficiency, and they will be the most beneficial for after SLED. In the second row, when the pannus is associated with severe symblepharon, it is better to do SLED along with conjunctival autograft. In the third row, when there is pseudopterygium and only sectoral involvement of symblepharon, it is better to do CAG alone and no SLED. And in the fourth row, when there is a bone dry surface, nothing is to be done. ASOCT is also very helpful in selecting such cases. You have to do ASOCT just to know what lies underneath. Suppose if the cornea is very thin, the chances of perforation are there when you remove the pannus. Sometimes the cornea underneath is very opaque and scarred and irregular. So in such cases also, SLED is not beneficial. So in the second column, this column is the one which will be benefited by SLED, because after pannus, which is sedimentous. So coming to chemical injury, which is the most common indication for SLED, the immediate management obviously is of wash. The intermediate management is of restoration of the ocular surface, like amniotic membrane grafting, and after that, the rehabilitative phase of visual restoration. So I brought in a few case examples, and this is the example of a Lyme paste injury, tuna injury, especially more common in this part of the country. And it was of a 5-year-old boy, and he presented to me on the third day with tuna particle in the upper fornix, and the whole cornea was diffusely hazy. And this was after I did the first surgery maybe on the same or the second day, where I removed all the necrosed conjunctiva along with lime particle and did an amniotic membrane grafting to for the surface to heal. So it healed well with symblepharon almost 60 degrees. And this was after 2 months. I allowed the surface to heal. So after 2 months, I felt that now we can go for visual rehabilitation. So this is the small surgical clip where I'm knocking off the superficial pannus and the symblepharon. The point I want to highlight here is that if we have done amniotic membrane at the intermediate or the acute stages, the dissection of the pannus is very easy when we go for slit, because there is a plane beneath the pannus and above the cornea. So once we reach that plane, the dissection is very easy and the underlying cornea is pretty much clear. But if the AMG is not done in acute or intermediate stage, then the dissection of pannus becomes all the more difficult and it won't be as clear as it appears just now. So once we are done with this dissection, the cornea becomes clear, and then I put in an AMG, as much conjunctiva as possible. This is I'm putting a and I'm sticking the AMG on top of it. Once the AMG is stuck, I'm just ironing it out so that it is stuck in its place on the cornea. After that, I take the limbal stem cells from the donor eye. This is the limbal stem cells I'm taking, and it should be the exact limbal stem cells. You should take minimum of stroma. And then I cut that piece of limbal stem cells into small explants, maybe 8 or 10 of them, and I place it on the AMG, which I have stuck, and we place it in a circular fashion in 2 rows. One is near the periphery and one is parapupillary area. So we place it in such a way that the corneal epithelial cells grow from the limbal stem cells in a circular fashion. So, we just spare the center of the pupil to avoid any haziness because of that explant. So once we stick it again on top of it, we place 1 drop of glue and we just make sure that it is stuck well, and the case ends with a BCL. So this is the pre-op, post-op, and the first day and the 14th day, the cornea pretty much gets clear very easily. This is another example, the similar acid injury in a kid of around 10 years. And this is after 2 months where it has healed and there's a symblepharon. This is first day post-slit. This is after 1 or 2 weeks. And this is after 3 months. So it is very rewarding both for the patient and the surgeon as well. This is another case where this was 6 months post chemical injury, symblepharon, and did a slit in the first. This is first week. This is after a month, and this is after an extremely rewarding result. But this story doesn't end there. We had again a recurrence of a localized LSCT having a superior symblepharon, and I went in and did a CAG on top, so it again is clear for around 2 years now. So this is another last case maybe, because this I have brought in just to highlight the difference between the slit and claw. This is a heavily vascularized pannus with symblepharon, and left eye is almost covering the pupil with hand movement vision, and the right eye is less severe. And this I did a huge symblepharon excision along with AMG and claw. Because it was a sectoral this thing, I did a conjunctiva limbal autograft, and the whitish area near the limbus shows that the limbus is working and the stem cells are giving a clear corneal epithelial picture. And this is the other eye of the same patient, and the results are even better. So to sum excellent visual rehabilitation, both the things are important. You have to select your case properly, as well as you take a limbal biopsy very meticulously to have a good result. Thank you.
Thank you so much, Dr. Dharmesh. That was indeed a wonderful presentation, and you very nicely highlighted there's so many cases and with such a good results. And I think the video also you showed would definitely help the beginners to start this procedure. And that was very right of you that if we do amniotic membrane in early stages of disease, that actually decreases the inflammation and also helps in later on while doing more of multiple surgeries we tend to do in these patients, and it is very much helpful. Now, I just had one question, suppose we are doing or planning an allograft when we have bilateral injuries. So what precautions would you like to highlight in such a situation?
First of all, in allograft, if the patient is a kid, I would like to do a temporary tarsography to avoid any loss of the either AMG or BCL. Second thing, we do give a good amount of immunosuppression for steroids for around maybe 1 or 2 months, and start simultaneously start with immunosuppressants like azathioprine in consultation with a rheumatologist, and then keep on the patient for quite some time. There were a few patients in which they had accidentally or by choice, they had stopped the immunosuppression and they came back with a recurrence, and then we again started them on steroids and immunosuppression, and they are fine. But immunosuppression is the key definitely for alloclaft.
Yeah, thank you so much.
Thank you, ma'am.
Any more questions?
Yes.
So I think we will move on to next presentation.
Yes.
This is traumatic subluxated cataract, and we have Dr. Aditya Sethi to present this talk.
He is being replaced. Yes.
Okay.
Hi, I'm Dr. Saiba Sethi. I'll be substituting for Aditya, who couldn't be here last minute. I'm sorry, it was unavoidable. So I'm going to start my presentation.
Yeah, sure.
So this is about traumatic subluxated cataract, managing the loss support. See, ideally in traumatic subluxated cataracts, there are only two scenarios. A, where you can place an IOL in the bag. B, when there is absolute loss of support and the IOL cannot be placed in the bag, and secondary measures have to be taken up. So here I will be highlighting two such cases. Of these two scenarios each. So this is a regular traumatic cataract case, which we thought did not have any subluxation on clinical assessment. The rexes was done as usual. There was no resistance. There was absolutely no problem during the rexes. I was completed. We routinely do utratas in all the traumatic cataracts, whether subluxated or not. A very gentle hydro was performed, knowing the sensitivity of the case. So just when the hydro was being completed, we noted that there was more than 2-quadrant loss of support over here. Now, luckily, the cataract was not very hard and it was prolapsing out of the bag. So we used this opportunity and we completely dialed the nucleus out of the bag using the cannula itself. There was, and just with aspiration, the whole of the lens was aspirated out. It was a slow procedure, but because this is essentially an anterior chamber phaco, ensure that phaco energy is kept to the minimum, if at all. But this procedure was done entirely under aspiration. And this was a very soft cataract, so there wasn't a problem much. It was a young patient. Now, following this, a CTR was placed, advisably so, because while doing irrigation aspiration, there is a possibility that you will be tugging at the area of the subluxation, which is very significant over here, and the bag may come off completely. So at this point, we thought putting a CTR is mandatory. And after putting the CTR, the INA irrigation aspiration becomes more achievable, and it's done without any problem. It's important to start with the area without the effect, without the defect. And because while you're doing that, the irrigation mode anyway releases your cortex a little more, and probably you'll be requiring less pull from the area which is subluxated. A routine foldable IOL was it was able to be placed in the bag and rotated. We checked for any vitreous in the AC. There was luckily no vitreous loss, and the surgery was completed without any problem. So this is one case where the need for CTR was highlighted at the right time. The recognition of traumatic cataract is very important at the right time, because then if you lose things and they get worse than what they can be salvaged, at which point it becomes easier. So the decision to use CTR will depend upon the amount of zonular weakness, but very often we don't suspect zonular weakness pre-operatively. So if the surgeons have UBM, this is a very good tool. We did a study wherein we did UBM in all cases of traumatic cataracts, and the number of occult zonular weaknesses in these traumatic cataracts, which clinically did not present with any zonular weakness, turned out to be 69%. So this is a very whopping number. So if UBM is available, it's a very good tool to do in all traumatic cataracts preoperatively with or without any clinical zonular weakness. And also the advantage of CTR is you get exact centration of IOLs. It can be placed anytime during the surgical procedure, even before the nucleus delivery in case of hard cataracts. And placing it early is a modified CTR technique. It may be preferable, especially for cortex removal, wherein you're tugging at the bag. Now, this is another case where of traumatic cataract, which clinically did not show any subluxation, but right at the beginning of the case, there was difficulty in completing the rexes. And just when the bag was being debulked, we noted that there was a zonular loss. And the VR surgeon was called for rescue and vitrectomy was done. So the case was taken over by the VR surgeon over here. The rexus was completed. This is a capsulotomy being done, and scleral side ports are being made. It's a good practice to have a VR backup in traumatic cataracts if preoperatively any problem is suspected. A lensectomy was done. Again, this was a soft lens, which was a traumatic cataract, and the anterior vitrectomy followed by core vitrectomy. Limited core vitrectomy is being done under AC maintainer. So the IOL is a foldable IOL is first. This is a secondary IOL, which is being delivered in the anterior chamber first. So there are multiple techniques of putting a posterior chamber intraocular lens in the absence of capsular bag. So this is a sutured scleral fixation lens technique, which we are highlighting, and this is being done by first in delivering the lens into the anterior chamber, and then one haptic at a time is being externalized from the scleral side port. There are special haptic holding forceps which are used for this, and it's tugged into a 26 gauge needle and externalized. Over here, we're tucking the haptics into a scleral pocket, which is being made with a 26 gauge needle again. There are various techniques to also secure the externalized haptics, and finally the haptics are being sutured in place. So this is a sutured scleral fixation IOL, and the case was completed successfully. So like I mentioned, there are various ways to put a secondary IOL when there is in the absence of support. And these techniques in these situations can help you put the lens in the posterior chamber. Now, modifications of these have left to safer methods of handling and externalizing the IOL haptics. Sutureless modifications are also available, like using fibrin glue-assisted IOL placements. So here I just want to maybe one or two points of tips and tricks I want to highlight while doing the SFIOL. So during the handshake technique, it's very important that the haptic is grasped at the tip whenever it is maneuvered through the sclerostomy site under the scleral flap. So this is one very important point. Second, only a specialized forceps which is made for this purpose should be used to prevent damage to the haptics during the externalization procedure. The haptics which are externalized through the sclerostomy may not stay in position during the externalization process and placement of the second haptic. So a skilled assistant is always required to hold the haptics of the IOL. So this is one challenge that surgeons face, that once the one haptic is externalized, it has to be held by a skilled assistant, which may not always be possible, and it also interferes with the surgeon's view as well as the mechanics. So there is a modification of this technique which has been developed by Beko et al., wherein they've used silicone stoppers or tires. So these are silicone rubbers which, I'm done, this is my last slide. Silicone rubbers which we use from iris retractors. So what you can do is, once the haptic has been externalized, those silicone stoppers alone, which can be obtained from an iris retractor set, can be pushed into the haptic while the second haptic is being externalized. So this way the surgeon is independent of any assistant required for this procedure. And once the scleral tunnels have been created, the tires can be removed. Another method is the fibrin glue, the glued IOL, which is similar to blood. So what it does is that there is lesser inflammation compared to sutures, but glue is expensive and has a short shelf life, which is one challenge with this. Many studies have established, however, that there is the results are very comparable to even sutured flap IOLs. Thank you.
Thank you, Dr. Shetty, for an excellent presentation. I just wanted to ask a few questions.
Yes.
The choice of IOL has always been the technique of IOL in subluxated cataracts. 1, 2, 3 choice: retroiris fixation, Yamana technique, and as you showed, the scleral fixation. Your choice and the advantages and disadvantages of both.
So our VR surgeon, I don't do SFIOs myself, but we at our institute, we have shifted from sutured SFIOLs to now Yamane technique and glued IOLs is what we do, because it's less time consuming. These are very, very effective newer ways that have been highlighted to us, fortunately, by some brilliant surgeons around the world. So yes, we have resorted to those compared to the mess of sutures, being confused with them, and the time consumption that comes along with it. So yes, the Yamane technique and the glued IOLs are what we are doing currently.
And any experience with the retroiris iris flow lens, retroiris fixation?
Yes, sir. The results have been, again, the selection of these cases is very important. One has to, we're doing this as a second procedure. The iris claw lenses are not done on the table, at least at our center. So we're doing it as a second procedure in patients who are aphakic, and they've had good results. Yes, again, it's a little, it requires a learning curve, but once mastered, I think about 10 cases or 12 cases, you should become a pro at it. And it's very easy once the surgeon gets accustomed to it.
Yes, thank you.
Thank you, sir.
Any other? Okay, so I think we'll shift to the next speaker. I'll invite Dr. Kushal Deliwala. He is a VR person in Ahmedabad, and his talk is on angiography. Dr. Kushal, welcome.
Thank you, Dr. Dharmesh. I will be sharing my screen. I hope my slides are visible.
Yes, they are visible.
Yeah.
Yes.
Okay. So thanks to CE Organizing Committee and Chairman Scientific Committee for this opportunity. So my talk is slightly different in terms of the angiography. So I will be talking about the latest kid on the block, that is the dye-less angiography. So is the transition from the dye-based angiography to dye-less in chorioretinal disorders inevitable? So let us see how it goes. So as most of the ophthalmologists are aware that conventionally fluorescein angiography and indocyanine green angiography have been mainstay modalities for visualization of retinochoroidal vasculature. The optical coherence tomography, or the OCTA as we all know it in short form, it became commercially available in 2014. So the conventional technique of the dye-based angiography generates two-dimensional on-pass view of the retinochoroidal vasculature. So here we see on the left side, this is the fluorescein angiography, and this is the indocyanine green or the ICG angiography. Fluorescein gives us the details about the retinal vasculature predominantly, while indocyanine gray gives us predominantly choroidal vasculature. Having said that, these are all two-dimensional views. So we can't see the superficial or the deep capillary plexus separate, and same applies for the choroidal vessels, which has 3 layers of choriocapillaries, settlers, and the Hallus layer. So this was overcome with the help of the Octa, where it gave an in vivo visualization of these vasculatures with a depth resolved fashion. And the most advantageous thing, it was a dye-less technique. So how did it work? So as we are aware of the conventional OCT principle, it's a cross section of the retinochoroidal tissue. But if we take multiple OCT scans at the same level, it detects the motion of the RBCs. And that is the principle of motion contrast detection, where it detects the motion of RBCs and creates a map of the blood vessels. So it gives this idea of how much the blood flow is there in the respective layer. So this is something which is known as a decorrelation signal. So if the RBCs move at a certain speed, it will detect the flow. If the RBCs move at a very slow speed, it cannot detect, and vice versa. If the flow is also high, it can bypass the few RBCs. So it gives us simultaneous visualization of structure as well as the vessels. So it has been proposed on the 3 different methodologies. We are not going into the details. And a lot of machines now available have this Octa technology, and with various algorithms which have been set according to the companies which they provide. So these are the few which includes Octara, SSADA, and Omega algorithms. So current, again, Octa devices are based on the principle of the spectral domain or the SWEP source. The beauty of the SWEP source, it has a longer wavelength, so it penetrates deeper into the choroid and even can go up to this chorioscleral interface. Again, the speed of the OCTs is very much high compared to the spectral domain, which includes 1 lakh A scans per second. And it's again comfort to the patient because the scan line is not visible, so they don't blink in between very much. So these are a lot of options available in the market which have this Octa facilities in them. And out of these available machines, these are the 2 machines which have this web source technology. The Carl Zeiss instrument is still in the research purpose, and it has been provided to only certain institutes, while this Triton machine is very much commercially available. I'm not going into the details of this comparison of each Octa devices. So this is the one which I have been working for the last 2 years with, and I will be sharing my experience with this machine with the help of few case studies. So this machine generates this beautiful 6 by 6 millimeter scan. It can also provide you the scans of 12 by 12 millimeters. Here, this is the superficial capillary plexus. This is the deep capillary plexus. It is the outer retinal avascular slab, and this is the choriocapillary slab. This is the composite density picture. And here also we can see this red and purple marks, which are indicative of the flow in the vessels. So these are the classically described superficial capillary plexuses, the deep capillary plexus. These are the nets which can be visualized at various segmentations. And same applies for the choroidal vasculature, where we can individually see the layers one by one with a segmentation, be it automated or manual. And this can also generate a wide field OCTA montage. This is a 12 by 12 millimeter scan where we have incorporated a mosaic of this. Of course, there are certain challenges related to the artifacts, which I will be discussing later. So whenever we interpret this Octa image, we have to be sure that what is the area where the image has been taken. We have to always look at the OCTA image, whether we have taken it at a proper segmentation length, because it is a machine-based tool. Their segmentation may be wrong, and in the interpretation can also be wrong. So we also have to look at the structural and correlate it with the OCTA image. Let us see some case scenarios. So this is a case of a 35-year-old male who came with a right eye dimness of vision. Here on the OCT, we can see subretinal fluid with an elevation which is suspective of a CNVM. And this is the dye-less angiography. It shows an outer retinal slab which is usually avascular. So if we see this net, it's a confirmation of the CNVM. Patient was given intravitreal anti-VEGFs. And here sequentially we can see how beautifully the net is resolving. All this has been done only with the help of the OCTA. So it is very much helping in the monitoring the treatment response. This is case 2. Patient has taken left eye multiple anti-VEGF injections for left eye PCV. ICGA obviously is one of the choices for the PCV, but due to its limitations of the availability pan-India, we have this technology of OCTA, and it helped us to see that here we can see a beautiful net of the choriocapillaries altered. Here this is the CNVM with the choriocapillaries altered and the net, and post multiple anti-VEGFs, we can see there is a significant reduction in this choriocapillaries network. This is a case of 65-year-old lady, and she had taken multiple anti-VEGF for the right eye. Here we can see this OCT, we can see some fluid. However, if we look at the OCTA, this is a typical dead tree appearance which we have been seeing, and it has been described in the literature, where this has reached a maturity and patient might not respond to significant further anti-VEGF. So there is a futile exercise to continue with the anti-VEGF. So we can also prognosticate the patients whether they will benefit or not. So this is left eye patient having supratemporal branch vein occlusion. And here we can see beautifully in the superficial capillary plexus, there is a significant capillary dropout with FSZ distortion. So these patients might be needing multiple injections. However, the deep capillary plexus is the one which helps us in more prognostication. So this is a patient with a left eye proliferative diabetic retinopathy. Here we can see a significant dropout in the perfusion, and just the posterior pole is the one which stays back. And this is another advantage of the software, where this is known as a reverse OCTA image, and it gives us black on white and white on black images. And this image had the opportunity from our team to get published on the cover page of the August issue of the Eye Journal 2021. So this is another case of a type 1 diabetic mellitus young patient with bilateral proliferative diabetic retinopathy. Here we can see a large net of neovascularization at disc. And this is his OCTA, because these are the patients where they might be having coexistent nephropathy, where FFA might not be advisable, but this OCTA can also give us an idea. Here, this is a classical NVD description, where we can see the entire net, and gradually it starts to regress after the treatment. So coming to the patients with choroiditis, here this is a lady, 46-year-old with right eye multifocal choroiditis. Here we can see a significant number of choroiditis patches. And beauty of this OCTA is that this is at the level of choriocapillaries, where we can see significant choriocapillary dropouts. Just 2 more slides. And post-treatment with Omna, Cortil, and immunosuppressants, we can see how beautifully the lesions are resolving, and there is a dropout is also improving from the choriocapillaries. So this is an indication that patient will improve his BCVA. And this is the other eye. Here we can see this beautiful Sattler's layers and the Heller's layers also with a manual segmentation. This is the same patient having the left eye scarred multifocal choroiditis. So there are some limitations, as I mentioned. It has a limited field of view. It has inability to detect the blood flow beneath certain detectable flow. There are potentials for artifacts. So not going into the details of the artifacts due to constraints of time, but there are a lot of artifacts which can be taken care with patient fixation, and we might have to spend certain time with learning curve with this. So here, this is the artifacts, the blink motion artifacts, where you can see these horizontal bands. So there have been upcoming advances to counter with the field of view, where we can see this beautiful image from the Plex Elite taken from Dr. Jean Francois, where he have shown that the entire view is very much wide field, and we can see a lot of dropouts in the periphery. So just to summarize, these are the gross differences between the fluorescein, the conventional angiography versus OCTA. Though fluorescein does not get outdated, it has its own advantages, but OCTA is something which we might have to adapt for the future, and both, I believe, they are complementary to each other, where the certain aspects of leakage are be provided by fluorescein, while the depth related resolution and segmentation will be provided by OCTA. So take home message will be know your machine and unleash its capability. And we have to be familiar with the software and capabilities of the machines which we are using, because this is a technology in evolution, and it's getting upgraded day by day. And we can't compare the OCTA devices because they each have their own algorithms and parameters set. And always make sure that we don't correlate only OCTA. We also have to look at the structural aspects of the retinal scans as well to arrive at a proper diagnosis and treatment. And obviously, like I mentioned, dye-based angiography has to be there as an adjunct when needed to make certain treatment decisions. But it's just a matter of time where the expenses come down. A lot of vitreoretinal surgeons will be having this machine installed at their setups as well. So thank you for this opportunity.
Thank you, Dr. Kushal. It was indeed an extensive talk on OCTA. Yes, it is. Hello. Yes, it is amazing to see how newer technologies can and more and more cases. So, is there any questions about Dr. Kushal from the panel? So I don't think it is. So I'll request Dr. Daivat Vasavda. He is also another VR surgeon from Ahmedabad, from Vishnagar, and he would like to talk on posterior uveitis. Welcome, Dr. Daivat.
Yes, thank you. Am I audible?
Yes, you are audible. You can start your share screen.
Yeah, sure. Thank you, Dr. Dharmesh and AGOS for giving this opportunity. Well, I'll be speaking about one case report in which we had a diagnostic dilemma. So she was basically a 26 years old girl who presented to us with complaint of defective vision in her left eye since past 20 days. She had a similar history in her right eye 5 years back, and she got treatment, but unfortunately she did not recover her vision. Other than that, there was no other ocular systemic complaints, no significant medical history. On examination, the right eye was with visual acuity was 6/60, and the better eye, which she had a complaint, was 6/9. Anterior segment was quiet, and other thing was normal. So this was the fundus picture. The right eye, as one can see, is peripapillary scar with chronic macular hole, and the left eye, the complaining eye, she had a parafoveal, as you can see, the two subtle lesions, the grayish lesions in autofluorescence also, which one can see the hypoautofluorescence surrounded by the hyperfluorescence ring. So considering this is a periphery picture, as one can see the whitish, lesions in the mid periphery and the pigmentary lesions in the far periphery. So this was the OCT picture where parafoveal intraretinal fluid is noted, and around at the level of RP, there is a lesion. So considering that, we did a routine investigation of CBC, Monto, serum ACE, chest X-ray, and in the suppository HLA-29, we advised to undergo with. After the first visit, she underwent all the investigation and coming back after 12 days with the investigation, and the activities increased. As one can see, there are two hemorrhagic lesions. The edema is increased, the vision is down 6/18. And luckily or unluckily, how do we say, the investigation were normal, including the HLA-29. So with that, we advise her to undergo intravitreal anti-VEGF injections in the form of bevacizumab. With considering non-infective etiology, we started her on oral prednisolone. Along with that, we asked her to consult a rheumatologist for further immunosuppression if at all required. So after first injection, the edema is getting regressed with the visual acuity 6/12, but with the history of other eye scarring, we did not want to take any chance, and we went ahead with the second and the third injection as well. So after the third injection, the edema is almost resolved, parafoveal lesion is there without any activity, vision was 6/9. After the third injection, patient lost to follow, and although we advise her to take rheumatologist's opinion, but due to some social stigma or some pressure from her in-laws side, they did not consult there. Then she is coming once again after the 6 months after the third injection with the same complaint. Because you can see on the OCT, activity is there with the vision of 6/80. So we planned once again fourth anti-VEGF, and I asked her, rather I insisted her to go with rheumatologist, but they were reluctant on starting on immunosuppressants due to childbearing age probably, or something like that. So once again, she lost to follow-up, and coming after 4th month. So once again, the edema is there, vision is 6/12. So these are the serial photos, as one can see. Mid-peris, there are many, whitish lesion around the vessels, and other than that areas also, which were almost hypoautofluorescence in the nature. This is the angiography. In the early phase, it was hyper In the mid phase, hyperfluorescence lesion were noted, and the late phase, hyperfluorescence lesion due to probably staining. So at that point of time, we asked our rheumatologist friend, and we started on azathioprine 50 milligram bill and considered for the 5th injection. So she was maintaining reasonably decent, but due to some GI upset or something, she stopped after 1 month. Till that time, she was fine, like with the stable vision, minimal intraretinal fluid was there, but she was symptomatically fairly okay. So we did not, continue further. But she did not take, although we advised, she did not take it further, the azathioprine. And after 8 months, once again, she's coming and with the same vision, same complaint with the 6-vital vision and the activity. So we opted for the 6th injection. And with that, we made them understood that you have to have immunosuppressant to take. And with 100 milligram, she had a complaint. So we gradually make it down to 75 milligram. And then gradually coming it down to 50 milligram. So after almost 8 to 10 months of duration, she had taken medicines and since stable after this 25 milligram now in the tapering dose. As you can see, the OCT, the minimal intraretinal fluid, vision is 6/9 and she's stable. Meanwhile, we plan to perform the ERG, although at our city, it was not as per the ISCV guidelines, but we planned ERG, and what we found was it was an abnormal retinal function in light and dark depression both sides. These are the serial picture of OCT, the first presentation after the injections, then again the recurrence. As you can see, the edema is going on and off, but the parafibrillation is almost remains the same. So, considering this patient, our probable diagnosis was probably the white dot syndrome, the incidence of which is very, very less. As one can see, the differential of white dot syndrome, there are nudes, which are tiny lesions around the optic disc and the paramacular area, sparing the fovea, which was not unlike our case. APMPP, which are diffuse larger lesions, which are good, very good prognosis. Azure, which is peripapillary atrophy and mottling, one can see. And RPC, relentless plicroid choroidoretinopathy, which are multiple lesions affect the oral retina. PIC, punctured inner choroidopathy, which was also not suitable in our patient, which is seen in myopic patients with tiny lesions and bridging scars at later stage. Serpiginous choroiditis, which involve only mostly of the times peripapillary and macular lesions. And multifocal choroiditis, which are larger lesions and bridging scars. So all this entirety was not suitable for our patient with the clinical spectrum. So we made the diagnosis of probably birdshot kind of choroidopathy, but the points differ from classical choroidopathy is it is mostly in Caucasians, like in Asians, it is very, very rarely noted. HLA-29, although we did from a very standard laboratory, it turned out to be negative. Mostly no pigmentation is seen as a sequel of birdshot choroiditis, but we had a far periphery RP pigmentation with blackish lesion. There are no, entry segment findings in the form of uveitis. I mean, entry uveitis, vitritis, or vasculitis in our patient, and very rarely develop the birdshot lesions, develop the CNVM, although we had in our patient. So the dilemma in this patient, whether we did a correct diagnosis, the order of treatment, the form of immunosuppression, we have option of cyclosporin, mycophenolate, but as I mentioned, the patient was very reluctant to start on the immunosuppressant, especially her in-laws. In fact, due to some of the reason, past 6 months back only, they had to file a divorce something. Probably due to this reason, probably not. So that was a very much psychological concern for her. And the overall prognosis of that particular patient, considering the other eye being scarred and this eye taken 1.5 years almost as a azathioprine, now seeing stable. So how to check this on a follow-up? Thank you.
Thank you, Dr. Daivat. It was indeed a unique case managed well. Okay, Dr. Nagpal sir is here. So Dr. Nagpal sir, hello sir, welcome to the session. You want to comment on
the time in public life, whenever something is to be put up as a argument We believe the eyes more than the ears. The eyes are given more weightage. And so I collected some of the large collection here in which we show you the way it presents itself and how the man is fooling him. This is a large number of slides put in.
Yes, sir. Sure, sir. You can start sharing your slides.
Slide.
That's the title. Do you see what I see? The artists at times befool our eyes, they play with our vision. What is visible is the truth. Even the eyewitness is believed. Hearsay evidence is less strong. Camera is believed more than tape recording. Next. Painters, photographers, fashion designers, beauticians, magicians, and large number of these self-workers have contributed to this talk which I am giving. You can see the bulge of the painting, and it is looking really real. This is related to the shadowing effect. Next. These things appear as if they are coming forward into our room, but there is nothing wrong. It's the artist's conception which has created shadows. Next. Similarly, showing breaking the glass. Next. These two portions, one is thin and the other is well formed, depicts the amount of flesh, elevation, the shadowing effect creates after. Next. Painting the road can drive you crazy. Next, please. This is a man standing on the floor, but the floor is being painted. You can see in Amsterdam, the road has got depreciated, but what they do is showing you something very funny. Next one, please. It was a piece of cloth painted like that road. Next, please. Believe me, this is the sink in your kitchen. It looks like an eye. Next, please. Illusions are created by fatigue phenomena of the photoreceptors. Latent period creates delayed responses from photoreceptors, and Coptic phenomena get attached to the photoreceptors. If we move our head towards the slide and come back again, you'll see the circles moving in the opposite directions. Actually, it is not happening. Next, please. Hello? They're counting the black dots. Next, please. This lady is in negative, and we take an impression of it by looking at it for 30 seconds and turn the eye towards the wall. You'll see the normal contour, normal color appearing on the thing. The brain develops a negative of the positive. These are all parallels, but they appear lines with different, but otherwise they are same. How many legs this elephant has? Looks like 8, but actually this is the normal. This book is open whether to the onlooker or the person who is reading. It's difficult. Next. The central circle is same size, but appears in company of the others as different size of it. Next one, please. Do you see some gray area between the squares? Now, where did this come from? Fatigue phenomena. You can see this violet color points rushing after each other. And in case you move the eye continuously to see the central point, the violet will turn green. This you can match with your respiration. Or turning back of the next. Artist hides the picture within each other. This is a written word, liar, where it appears the face of a man. There are 10 animals and leaders of the politicians, and you see 10 faces in the tree. Jawaharlal Nehru, Tilak. Next one. This is a small child which has been drawn and shows itself as the legs moving. Next, please. Zooming effect can create illusions. Actually, this is very different than what we saw at the beginning. Next one, please. A horse and a man. Next one. This is a animation of the plus. Next. Take it back. This scenario of the street shows everybody moving around except the one with a newspaper in hand and trying to see. It is partial animation which the photographers do. Next. This circle creates confusion. Next. All the three gentlemen are same size otherwise. This is a frog which starts moving and gets turned itself into a horse. This is a picture of the fundus of the man who was looking at the girl telephoning. And we have taken the picture from the fundus as it would appear as shadowing effect, fatigue effect. Next one, please. How many children are there? $11, $12, and that makes it 12. Yes. This is very funny. Before 6 beers and after 6 beers, the woman looks like totally changed. Next. 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 Do I have time?
No.
Yes, sir, you can continue.
Evil is always seen in the good. Bad, evil is similarly teach, learn. Me. Next, please. Magicians create mass illusions and tricks, amazing results.
Next, it's Kevin James.
This is all illusion. You can see in this illusion how they change their clothes. Playing with the moon, superimposition are the photographic tricks. It looks as if one is playing football. Dancing to the tune of moon. Yes, clearly the highway. Thank you.
Thank you, sir, for an and illusions. We really enjoyed looking at those pictures.
Thank you, sir. Nice seeing you.
Hello.
Thank you, sir, for making it to this
Macular,
session.
sir. Macular.
Oh, Macular. I didn't understand.
Nice seeing you after a long time.
We're getting old.
All of us. All of us, sir.
You have
Hi,
the
sir.
central to
Sir, pranam. Totally here.
अरे तुम तो यहाँ कहाँ पहुँच गए तो तभी दिल्ली में थे I saw you coming back from Delhi.
Oh.
How did
Thank
you
you,
break
sir.
your tooth, Bakulesh?
Sir, what do you?
Did you hurt yourself in the tooth? The tooth is broken.
या वो पहले से थे अभी मयूरी देख लो सर तो टूथ अच्छा हो जाएगा
नमस्ते सर Chatalia bhai, nice seeing
Thank you very much.
Yes.
I hope it was useful.
Yeah.
Yes, yes.
Yes, sir, definitely, sir.
It was my pleasure to attend this your session second time. Earlier, I had attended this session in 2016. So really, it was a pleasure and great moment for us, all of us rather, to be in company with you, sir.
Thank you very much. That pleases me. बंद कर दे.
Thank you for coming. Now I would request Dr. Chotalia sir to come up with his talk. Dr. Chotalia is a very senior practitioner in Junagadh and Jodhpur, and he always has some or the other new topic on his way. Welcome, Dr. Chotalia sir. You can start your screen share, Chotalia sir.
Right. Am I audible and visible too?
Yes, sir, both.
Right.
Yes.
Okay, thank you. First of all, I would like to thank Dr. Priya, Scientific Committee Chairman, as well as the entire organizing committee of AGOSC 2021 and Executive Committee of AGOS 2. So actually, I prepared this presentation long back during first lockdown. My slide is not moving. Shall I go?
So you need to do slideshow.
Okay.
This is not in slideshow mode.
Is it okay?
The icon after that. No, other.
This one?
Yes.
This one or this one?
Yes. No. Last
This
one. Yes.
No.
Yes, sir.
Okay. Now
it will move.
Right. Okay, thank you. So during first lockdown, this was prepared, and I am trying to highlight those moments which turn out to be quite funny, as well as some they gave us some moral too. I have classified these corona effects that I experienced into 3 stages: pre-corona stage, for-corona stage, and post-corona stage. In pre-corona, on 13th November 2019, I met this Babu Moshai, Dr. Suvin Bhattacharya at Kolkata during banquet of IMSICS conference. He asked me, "Aapko kya corona hai?" He intended to ask, "Aapko kya karna hai?" I heard corona word for the first time there. On the last day of AIOSC, 16th February 2020, I saw a group of short-statured people with semi-closed eyes at the reception of the hotel. I asked the receptionist whether they were Chinese. I thank God when she told that they were Japanese, as corona started migrating from China. As I leave home at 7 a.m. for my clinic at Jaipur and reach back home at 6:45 p.m., my wife told me once before few months that pota mate to samay kaadho. I realized that her suggestion expectations turn out to be right during this first as well as second lockdown. કે મારે પોતા માટે સમય કાઢવો પડે. At present, during that lockdown, I found time for pota, meaning mopping, as well as myself in Gujarati. And I did find time for potana, my better half, as well as daughters. I stayed with my wife for almost 24 hours, again after 37 years. As earlier, we stayed together for 24 hours during our honeymoon. We could have videos, chats twice with my daughters as well. We spent nostalgic moments too by playing Ludo online as well as by sharing past memories. I found variability in husband-wife relationship during this lockdown. After engagement, made for each other. After marriage, made for each other. And for Corona lockdown, made, MAID, made for each other. And post-Corona lockdown, made due to each other. I had a couple of missed calls from my elder brother during the lockdown. After an hour, when I phoned him, he told about no reply from me twice. I clarified that during first missed call, I was washing clothes in the bathroom, and during second missed call, I was cleaning the utensils in the kitchen. Then he thanked me for reminding him about housekeeping, and he told me that he will talk later as he had to go for sweeping and cleansing. While during first lockdown, Ramayana was re-telecasted. So while watching Ramayana on TV, I gathered one preaching message from Kumbhakarna that मैं कुंभकर्ण घर में सोया था, सलामत था, बाहर आया मारा गया. So the same situation was with all of the people during this corona. Another inspirational message from Sri Hanumanji in present threatening conditions of doctors as well as during this lockdown. Sri Hanumanji thanked God for being blessed with flying ability so that nobody could attack him while he was on the way to bring Sanjeevani for comatose Lakshmanji. I thank God that I am having 3 balconies in 3 different directions in my house. So I use them turn by turn for drying the clothes so that I can show different neighbors that I have to wash clothes only twice a week. But when my better half came to know about my schedule, she told me to go to the terrace for drying the clothes so that no neighbor can know about my duty and I can see them all in their balconies doing the same. During this lockdown, frequent washing of hands with soap and sanitizer was the only thing that made me feel that I was getting scrubbed frequently for performance of surgery so many times throughout the day. And actually life of an ophthalmologist became like this during Corona. See, one could master this technique of capsular axis because we had ample time to perform all these things at home while during household duties, as we could not attend our hospitals in those days. So this is a gesture of an ophthalmologist to show how he could do the same thing while boiling the milk. So Rexis is almost complete rather. Right. When 2 lockdowns were over and I had to go to the clinic, I realized that I had to persuade few patients with cataract who were very much keen to undergo surgery earliest, even though it was not an emergency, but elective surgery. I had to clarify them that they would have to undergo additional lab investigation for COVID-19, which may cost them to almost the charges which they were to pay me for a routine foldable hydrophobic IOL. But some things we expected that patients and the relatives might give up the habit of coming closer to the doctor while giving their history about the onset and progress of their symptoms, as we all face this thing. People will follow the protocols of maintenance of sanitation, hygiene, and of course, social distancing too. And people may change their minds to give due respect to doctors, healthcare workers, as well as policemen and others associated with other essential services, all of them performing their duties without bothering about their own lives. Just a couple of minutes. Funny conclusion which I gathered that Donald Trump was like a wife who thinks that she is the only person in the world being always right in all the matters, irrespective of situation, place, and whatnot. And as this cricket, as such, it was postponed during the lockdown, but these two umpires discussing that due to mask, they could not recognize the batsman and thought that he has come to bat second time or thrice. And then batsman regretted that he has not changed the gloves, otherwise he would not be identified. And during job interview, so the thing might happen that interviewer may ask the candidate that which batch, and the candidate may say Corona batch, and then it is likely that the interviewer may tell that okay, stay home, stay safe. Tons of thanks to my dearest daughters for preparing slides of the PPT and son-in-law in guiding installation of Zoom. I could not forget the thank my dearest as well as nearest better half, without whom this presentation would have been a vacuum. Thanks to the learned audience for hearing and bearing me patiently. I apologize if I have hurt any of you or bored. In spite of it still somebody feels like that. In our Kathiyawadi style, meaning by what you can do whatever you want to do. And last but not least, I pray to great God to protect all of us and the entire world from this pandemic corona. And I wish that there should not be like a third wave. Thank you.
Thank you, sir. Thank you for an excellent humorous presentation. And we all went through such a situation during the first and the second lockdown. So I think with this, we come to the end of the session. And I thank all the organizers as well as the AGOS committee and the scientific committee for allowing me this session. Thank you. I think this is it.